So welcome to the last session of the program, and the topic of discussion is very, very important, relevant, and I think one of the most important issues over which we normally have, aggressive reactions and all sorts of, allegations coming from the patient party. And the topic is disclosure of medical error. So if I may ask you, who all have actually done this activity in real life? If you would like to share your experience. Has anyone done it? Okay, I can see two hands. Okay, Dr. Menon, go ahead, please.
So this had happened recently where something that happens very commonly. In fact, medications for one patient was given to a different patient.
Mm-hmm.
So that was the event.
Okay.
So this had happened a couple of weeks back in the ward. So once it had happened, we had actually gone and communicated to the family. The good thing was they were there, they were already there for the ward for around 4 to 5 days. So I had a fair amount of rapport. So I was able to sit with them, explain, and the medications that were given were not very problematic. So in that sense, okay, it was more of an easier task. But one of the things that always happens specifically is with regards to medications being given. So in this instance, at least, the person did not have much sedation. So, and as we have continued to say, the fact that I had engaged with them for over 4 to 5 days, that also helped to calm their nerves with regards to that. And they appreciated the fact during the time of discharge that we had actually communicated.
So although you say it was an easy case for you because you had already built rapport and the drug had not done any damage to the patient, so probably you were comfortable. But you had the choice to hide it. You had the choice to hide it. Am I right?
Yes.
But I'm glad that you volunteered to share the information. And you also said that they were thankful and they were appreciative of the fact that you did not hide it from them. You shared with them. So I think, thank you for sharing that instance. And usually when you share with them, they are, thankful for being open and honest with them. That's what is my learning also. But I want to hear others. Dr. Harimohan, I think you wish to say, please go ahead. Yeah.
I haven't gone to say to patients anything very serious. It hasn't happened. That situation had not taken place, but maybe like one is when a crowded consultation room, sometimes you miss the file and we keep talking so much about another patient and then everybody get confused. Then I would apologize and say, sorry, this happened. So now I'm very careful. I reconfirm with the address, and because the same name can come and so many files are there. Sometimes that has happened, and that I told. In abroad, both the places, we had regular morbidity and mortality meetings. That was among doctors, but it was not revealed to the patients at all. But that we went concise. We used to do a proper detailing, and sometimes even the names of the people who could make mistakes came out, but it was discussed in a good manner, it was not a blame method. So that mortality and morbidity meets helped us a lot in disclosure, but it was not disclosed to the patient. It was disclosed among the profession. It was there. That we don't find much happening here. That's what I found out.
I agree with you. Thank you for sharing that. Yes, Dr. Sonia, go ahead, please.
Madam, it is regarding a system failure, sort of. The other day, there was a code blue that was announced, and the code blue, it has to be the major manpower has to be generated from the ICU. and somehow they had turned down the volume of the system or something, and the code blue announcement did not reach them. So eventually the resuscitation was very ineffective. By the time patient was shifted to the ICU, it was very late, and we had to lose the patient. He was a very sick patient, but I mean, having lost the patient was very difficult for us to handle, and we felt very bad about it, and we had to apologize, and because wife was a staff nurse again, so she understood that there was a system failure and nobody rushed to the scene as it should have happened.
And she accepted?
She accepted because about a half an hour back, I had communicated with her, and I had also told her that since the patient is very sick and they were totally sapped of all their financial support system, I asked them whether you would like to shift the patient to the ICU. So she was a bit reluctant. And I told it he was critically ill. He actually needs ICU admission, but she herself said that doesn't look like there is a point. But at that critical point, she kept saying that there was a system failure and nobody rushed to the scene, although it was her decision not to shift the patient to the ICU. So the emotion.
Did she react in any aggressive manner?
Yeah, she reacted in an aggressive manner for a while, a couple of minutes, and then she got composed, and she probably, it was an immediate reaction. Later on, she calmed down, and probably she thought about the whole thing and reflected that she herself had not asked not to shift the patient to the ICU. So that way we could save a situation, but then again we felt very bad, because a couple of times earlier we have resuscitated him effectively.
Okay. Thank you for sharing that, please. Thank you. Yes, Dr. Paul, please go ahead with your experience.
Yeah, mine is like most of you are aware that anesthesia, we give subarachnoid block or spinal anesthesia, there will be hypotension. And what I'm trying to say is like what Rafiq had projected last time, like look-alike drugs. Okay. So there will be always a vasodilatation and BP fall. For that, you give vasopressors. In this, like there are two drugs, like which is one is ephedrine, another one was adrenaline. Those two from the Neon company look alike. So one like adrenaline, you all know that it's given in cardiac arrest. That 1 milligram is given in a cardiac arrest, where instead of ephedrine, adrenaline was given by the postgraduate who loaded the thing. So immediately the effect is like severe vasoconstriction that will cause a increase in the BP. So his BP, and this patient is conscious. You all know that it's a subarachnoid block. So it was very high, 200, 250, and patient was complaining of severe headache. So like I asked my postgraduate like whether something has happened. He said, no, sir, I gave ephedrine. I asked him whether it was adrenaline. And the patient was also a little upset because after later he was asking, but I had to, I didn't say the right fact, what is the reason. And I didn't know also, but after this postgraduate, like leaving, before leaving, for the sent-off party, he disclosed the fact that it was the drug what I gave was wrong, but you are right. So, but the patient was like, I didn't tell the patient also, and I had the suspicion. But later this man, he confessed. It was a grave mistake, and definitely something would have happened, like a hemorrhage. Like BP was around 220, we just come. So nothing happened, luckily. And I didn't scold him when he said the right thing also. Like after 3 years, he was scared actually, the postgraduate.
I know most of the times, whenever it happens, one is we don't share with the patient party Because if we think we have been able to manage, we think there's no point telling the patient party. But then we have to also remember that patients have some rights, and I mean, we really need to manage this situation well. I understand your concerns. Thank you for sharing that case. Yes, Dr. Lata, please go ahead. Yeah. Dr. Lata, are you there? And she got disconnected. No problem. Yes, Dr. Asha, please go ahead. Yeah.
My issue was basically with a procedure which I had done, like for a thyroid nodule, you do 5-needle aspiration cytology. An FNAC was done for the patient, and this was maybe around 10 years back. We did an FNAC, and we sent the specimen to the lab, and they send it for, we don't have an FNAC a pathologist in our hospital, so they send it to a nearby place, maybe 50 kilometers away to a place, and then the result comes maybe within a week or so. So it was given, and the patient was asked to come back after a week to collect the results. That is a usual procedure that was done. 1 week later, when the patient came back to collect the results at the lab, it is, nobody has such a patient there. Nobody is entered that, no results, nothing. Even the specimen is not sent from, it doesn't see in the records it's been sent. So it was a huge issue, and it was a young boy who had come, the lady's son had come. It was a slight, a bad scene there, and I was called there actually because it was my patient. The scene was in the lab, so I was called there. So it was 10 years back, so I had maybe around 20 years of experience. So I was really, not so young a person, so I could manage the scenario a little. I could talk them and calm them down and bring the son to my room. I brought them from there to my room, and I could settle them and talk to them. Yes, there was a mistake. Somehow misplaced the specimen. It didn't go. The specimen didn't go from the lab. That's what happened. So, but somehow I could manage and save the situation and convince the patient to bring the lady back. And I could do the procedure again, and the procedure went again well. But then it was a big scene there. It was a gross mistake that the specimen was totally misplaced.
Especially if they were fearing something very serious. So according to them, it must have been delay in diagnosis and treatment, which would be very, I understand. Yeah.
And she had to go, and she had to undergo the procedure again.
Oh, yes. That's another additional
trauma too.
Yeah, absolutely. Thank you for sharing that case. I think, yes, Dr. Rakhi, please go ahead. Yeah.
Yes, mine is also, of course, procedure related. If I have to start saying, I had like all post-op cases in the beginning few years. I used to get a lot of complications. I have to be very, frank about that, because I still remember that case. There were two sisters and one brother. So I operated on both the sisters, and the sisters recommended this brother to come and get his surgery done. So both the sisters were okay, and this brother, he was much younger brother, and I got him operated, everything. And the next day he was coming for the post-op review, and I'm looking at his eyes. There's no IOL. So there was an IOL drop. So I had put in the IOL, and probably, I don't know, maybe the posterior capsular bag was not, or maybe I had created a posterior capsular rent at that time, which I didn't recognize. And this IOL has dropped. So the first post-op visit itself, I knew there is something, and I doubly checked by putting a +10D lens. And he was reading 6.6 with +10D. I was like, Bapre, what is this? So now what to do? So he's a young fellow. So I just thought, and I immediately, called up my vitreoretinal surgeon friend. And I told him, see, I'm sending this patient. You just do whatever it is. I'll pay for that. And I paid for the surgery, what he had to be done. And those patients, those bystanders, everybody, they're still my patients. They keep coming back. And I think I didn't say that it is my mistake, but I think it was very evident. That's it.
So thank you, Dr. Rakhi. I think it is not easy to come out and honestly accept your mistake, even among your friends. If you have come out, it's a great courage one requires to talk about this. But yes, we all do, mistakes, something like this. Although it's one of the complications, it's not an error, honestly, what you shared. It's one of the surgical complications. There can be a IOL drop. But thank you for sharing that. Thank you. Yes, Dr. Mini, go ahead, please.
Yeah, sometimes we are forced to cover up the mistakes that has been made by our staff also, because they might not have carried out the proper medication that we have ordered, the proper investigation that we have told. Sometimes they might have forgotten to show us the cases when we go for rounds, and later the patient bystanders will come to us and ask, "Madam, we didn't see you in the morning." Then I will ask the sister what happened, because this was a patient whom I had operated yesterday, and since today evening I have up to today evening I have not seen the patient. So it is very bad. We feel guilty about it, because just because we on the round some 15 patients we see, and this patient might be on the other end, the sister will say, "Oh, I misplaced the case file. A patient just came in from the poster board," like that happens. So then we will go again and we'll apologize. Sorry, it was a mistake from the staff part, because the case sheet got misplaced, and now I am here again to see you. Please don't feel bad about it, and everything will tell that. And another case, sometimes it happens when we have so many consultants working together, and so many like procedures to be done, because say for DNC, for example, if you have 2 or 3 patients for
I think it is not being sent. I don't know.
for DNC, for example, DNC and 3 consultants are there for doing that DNC procedure. Then sometimes the anesthetist might place the patient for anesthesia onto the table, and you might get a call, "Yeah, the patient is ready, you come and do." Then one day when I went, I found my colleague has done the DNC for my patient. Anyway, the procedure was correct, but only thing, the patient got chased by the anesthetist. Okay, I said, "Madam, fine, you have done what is needed has already been done. It's okay. But anything, and it is only the difference is that the doctor has been got changed, so no problem. The procedure is correct, so don't worry." And later, of course, because it was an anesthetized patient, we need not tell also. The procedure has been done for the patient. We had a talk between ourselves and we settled.
I think
So,
these are minor cases you could handle very well. It's only when there's a error of a kind where the patient has been harmed. Probably that's what is very challenging, and there the real test of your ability to handle that situation. Something. Yes,
yeah,
Dr. Vasu.
sometimes.
Madam, this was several years back, maybe 25 years back. I was young then, and I had done a case of tonsillectomy. And in the evening when I came for rounds, I found a small clot. So I took the patient to the OT. The anesthetist was there. It was looking so tempting that I just, the anesthetist was standing beside me. I just pulled that clot out. As soon as I pulled that clot out, just blood just gushed out. But I told the anesthetist, "Come on, intubate him. Intubate the child." The child was intubated. I managed the case. I came out. But the thing was, I had just told them I want to take the patient. There is a small clot. I'll just take it out and come. But then it took about 15 to 20 minutes. The patient had undergone again a GA. I hadn't taken a consent. Nothing. And because I was young then, I didn't think of those things. I anyway went outside and told the patient that there was a sudden gush and we had to operate again, and it was done. The patient is fine. So they didn't have, but I didn't tell them about, neither did they. Were they aware that they had to take a consent? I just told them the fact that there was a heavy bleeding and I had to do a thing. But the best part was 25 years later, that girl's daughter came and did a tonsillectomy from me. That was the best part.
So maybe, 20, 30 years ago, things were not that bad. Plus patients never, questioned, never doubted, never, even if they had doubted, they would not verbalize that doubt. They'll talk between them, but to the doctor, they never had the courage to come and ask. But today, how things are and how unsafe it is now to, play with something like this. You don't know where you may ultimately, and thank you so much for sharing your experiences. Dr. Lata, I think you had raised your hand. Do you have anything to share?
This is actually during rounds, we had a patient with pneumonia who was admitted. So initially his blood counts were towards the higher side. So after 4 days, we just repeated the investigations. So I just saw that his hemoglobin came as 6.3. Rest all counts were normal. Then before telling that he's having anemia, I just tried taking history whether he had any symptoms or any problem. So there was nothing. Then once more, I just checked the report. So it's the same name, but age is different. So we had 2 people with the same name.
Oh, I think we lost her once again. There's some network issue at her end. I believe that's why she's getting disconnected.
It is raining here, madam.
Oh,
So actually, I didn't have the courage to tell them that the reports got exchanged, but I spoke with the staff. I could not disclose, like I didn't have the.
If you switch off your video, I think your audio quality will improve. For a while when you're talking. Yeah.
Okay.
Go ahead, please. Yeah.
So there was an error, that is the lab reports got exchanged, but I didn't have the courage to tell the bystanders that such a thing had happened. But I spoke with the our staff nurse and head sister and told them that such things can happen. We should be careful in the future. But I didn't disclose it to the patient because I didn't have the courage, and how to tell them I didn't know.
And this is a recent case?
Yes, ma'am. It was no, not before starting our. I think maybe 2 months back, 2 or 3 months back. It was.
Yeah, in the recent, maybe 6 months, maybe 3 to 3 months. Yeah. So imagine that. I mean, even at this age, we find it difficult to communicate to the patient family in case if there is an error. Imagine the youngsters. Imagine the youngsters. I mean, who has to do this and who don't know how to actually go about. Because I think this is one thing we are not trained into. I don't think anybody has ever had a formal training in how do you go about disclosing a medical error. Has anybody had any training? I don't think. Whereas this is such an important communication that you need to be making to your patient and their family. And if you don't know, then everybody will try in their own way. It might work, it might not work. And that's why most of the time it ends up into aggressive reactions from the patient party. Or even sometimes we don't know how to handle, or we try to cover up. And much before that, your staff sometimes go out and disclose all that information with the patient family. I'm sure you must have all had that experience also, where your technicians or your nurses or somebody from your team might go and speak about it in a very casual way to the family. And then later on, it becomes very difficult for you to actually explain to the patient party what exactly happened. So I can see a couple of comments in the chat box. Dr. Harimon has written, I think disclosure depends on outcome of patient. It's easier if outcome is not fatal, less complicated, and not permanent damage. But fatality and permanent damage, then so many issues come up, like legal indemnity, fear of isolation, aggressive reaction, and mostly. I completely agree. I think these are the reasons which hold us back from coming out in an honest manner to the patient and the family member. And I think especially wherever we are able to hide, given the choice, I think we will hide. Am I right?
Yes, sometimes what happens is we might be planning to break the news in a stepwise manner, but somehow the staff will break it all of a sudden. And then the whole situation turns out to be difficult to handle it also.
I agree.
So, yeah.
I completely agree. So Dr. Nambiar, you have written the discussion is not audible. And if I may ask all others, is the discussion audible or is there some challenge in the volume?
Yes.
Dr. Nambiar, I request you to look into your system. Maybe there is some, volume button if you can increase the volume. Also, for the last couple of sessions, your camera is not on. So I was assuming that maybe you are, keeping it off because you don't want to have your camera on, but I don't know if you know that your camera is off. Dr. Namir?
I think there is some issue with his driver, video driver.
I think so. I
Yeah,
think
yeah.
yeah.
I'll call him, ma'am.
Yeah, I request you to speak to him so that he knows that maybe he's not even able to hear what we are saying just now. There's a
Yeah.
possibility. So I think thank you everyone. That was a wonderful share. And I think what is the feeling after this share? Some key points from these experiences. What is the existing status of this?
We're all scared to tell the patient the truth.
Yeah, really. We find somehow if there is a mean, we will
No,
somehow
we want
try
to tell, but we are scared to tell, thinking of the consequences that we'll have to face. So we think it is better to keep quiet and manage the situation, see that there is no problem and get out of it.
I agree.
Especially in the present scenario, it is very risky to do the thing, number one. But the problem also exists, as you said, if it is told by somebody else, then we are all the more in a very embarrassing situation why we didn't tell earlier.
Absolutely.
So that also we have to be careful.
I completely agree with you, and that is where they feel that we have either deceived them or we have willfully, kept the information away from them, and then they may doubt that there is much more than what has been disclosed to them.
Yeah, even if there are inherent complications
And
also,
the
they
guilt of hiding.
Sorry, I think somebody's. Yeah.
Guilt of hiding it from the patient, that is also there, and we'll be scared that if they come to know about it somehow again, that will be a problem.
So imagine the kind of anxiety feelings and like you said, guilt feeling each one of us experience when we hide something like this. I really understand what you're saying, and I'm sure all of us must be feeling the same when we are not able to come out of them. Anything else from the present discussion?
even if it is an inherent complication, which is not a deliberate complication that has been made by us, even then we feel afraid to reveal it to them, actually, in the present situation. Because it is a natural course of event for which we have not been attributable, but still sometimes we find it difficult to tell to them also.
The problem is that in that particular situation, even if we tell, they may accept and go. But later, when they have some other problem, they will correlate it with this and say that this was a reason for me suffering. That is the worst part.
Now, because everything is attributed to negligence only,
Yes.
that is why.
Yeah, I completely agree with you. And actually what you're saying is proved by studies also. A lot of studies have proved what you're saying. I completely agree. Any other thought by anybody? I saw one message, I think by Dr. Rafi in the message, sleepless nights. I completely agree with what you're saying. Definitely, I think whenever something like this happens, one feels very restless and it takes a lot of time to get settled and go back to your normal routine. For me, I think one of the learning, like you shared, that whenever you are able to talk effectively to the family, you are able to, minimize the damage. If I, bring here Dr. Menon's disclosure or Dr. Asha's expression, like when you talk to the family and address it, you can, resolve things. Only thing is, do we really know how to handle that and how to minimize that damage? So Dr. Rafiq has joined just now, and Dr. Tanzil, do you have anything to say about any experience that you have had with us, considering that you are younger,
Yeah.
So what has
Actually,
been?
I was driving all the time and I was hearing all the discussion. I just want to share one of my experience, even though I'm not involved in this particular case. A couple of days back, a baby, is only a newborn only, less than 1 month here, the baby was brought to casualty, saying that they were suspecting baby is having some pain in the axilla because the baby was having incessant cry. So the casualty people took an X-ray. They found some radiopac thing. So it was a needle. Later it came as a needle which was used for taking samples. So when we take sample from newborn, we will break the needle from the hub and we'll use the needle only. So it got embolized. And it was happened from, it was reported in a hospital where we do critical care activities. And on yesterday, I got a call from another hospital. I was involved in casualty activities for a while previously. And the manager was asking, sir, there is a case like this. So I know that case. No? How this hospital, this particular hospital involved is that that baby was born in the previous hospital, and after discharge, the baby was taken twice to this particular hospital for taking bilirubin. So then the issue is that from where the needle got embolized. Now the bystanders are creating issues and they're approaching the second hospital where the baby was taken for bilirubin, sampling for bilirubin. So that manager only called me yesterday. So he was asking, is it possible to have this needle embolization? I just went through the articles and all, and I consulted the vascular surgeon also. He said it's possible. He had already seen not less than 4 cases in his career. So I called this manager and told that it's possible, it can happen. But in my opinion, why this happened is it could have prevented if that staff immediately reported that such thing has happened. Is not able to pick the needle. At that time, they could have done they could have applied tourniquet and they could have removed the needle from hand itself, and they could have prevented migrating to axilla. It can even migrate forward and it can reach up to the heart or even lung. The situation might be much problematic. Anyway, what I told this manager is just tell them that you are not sure whether it happened from your staff or from the previous. Both are connected. Both have a good relationship with me. So I told tell them that we are very much particular about taking care, very much following protocol of taking a sample from newborn, and such kind of errors cannot happen from our side. So we can take the responsibility of that. But I need your opinion about that. How to solve this issue?
So very honestly, you're saying this to them that it can't happen in our sector because our staff is very experienced, and if it can happen, my staff have reported.
Yeah.
I think it's more like a saving the situation. But
I just want to save them because now the issue is solved. The foreign body has been retrieved. Now they want compensation, and there is no solid evidence that this has happened from the second hospital or first hospital. So I don't know up to what level I am honest in this case. I just told them to tell them like that. This only. Today was the meeting with this patient party. I have not got any update from them. Probably they will call me tomorrow, but I need your opinion.
Both the hospitals should share these points.
So compensation in what sense? Is it the treatment cost or it is the compensation for the?
Sometimes this patient party will ask for anything. May not be confined only for the treatment expenses. They'll ask for huge amount of compensation. So it's better not to say like that it has been happened from our side. But I told this manager that ask the staff again and again, try to find out whether it has happened from there. And at least
Nobody will admit. Rafiq, nobody will agree. Do you think any staff will come out and say, yes, it happened?
No, I'm not expecting so. But we can say the staff that this can happen, this can happen. If it happens again, what you have to do? You have to apply a tourniquet over there. And
you tried it with staff eye. That's good, yeah. So,
That-
so in this situation where something like this happens, of course, I'm going out of the topic that we are discussing. In this case, I want to bring up, to all of you, because most of you are very senior in the profession. There is a program by law universities and also the courts. They have mediation officers. So there's a program. I'm sorry, I think Dr. Nambia's mic is on. I need to.
No, it is off.
No, now it's done.
Now it's
So,
off.
Lakshmi's mic is on.
Yeah, it's off now. So, there is a mediation program offered by courts and law universities, which is open to lawyers, and it is also open to professionals. So I would really recommend that some of you take up that course with the law university or with the court. Check with your court. I think it is usually in the court that they will hold it, because in the time to come, we will require people who can do the mediation between the doctors and the patient party. So I would really recommend some of you to take that program. It's not a very big program. I think it's 3 to 4 days training or 5 days training, but quite rigorous in terms of helping you understand how you go about mediating and bringing both the parties to a level where they kind of understand that we need to resolve the conflict. So I attended this doctor-patient conflict resolution program in National Law University, Maharashtra, and gone to Bombay to attend. It was a 2 days or 3 days program. I think 2019 I attended that program. But after that, I came to know that there's a mediation program that you can attend to actually understand mediation in a very, formal way. So I would really recommend some of you to take this up, because we will need this service also in the time to come.
What's the name of the course, ma'am?
Mediation program. It's called mediation program. Yeah. I think I would request, suggest some of you to at least do this with the idea to be ready for the next situation. So thank you, Dr. Rafiq, for sharing that case. And I think it's a very complex case. The party knows, and they know that both the hospitals are now, they have no way to prove that it hasn't happened in their setup. So they have, and of course, it's a very complex situation. So, so we have understood that we find it difficult to talk about disclosure of medical debt. If I may ask another question, what could be done to make this task easier? Error can happen, and it's not just the error, even complications, or even when the result is not as expected by the patient party. So they will not say it as a something that was possible, but they will take it as a error from our side, something that we promised and that has not happened. So can you think of what could be done to make it easier for us to handle this situation?
Immediately acting on the issue may take some of the pressure off, intensity of the case.
So that means if you are able to immediately communicate, but honestly, studies suggest that we want to either avoid it, or we don't want to do it, or we want to postpone it as much as we can. But I agree with you that if we are able to promptly, after having all complete information, if you talk to the family, that's a very good way to, communicate. Okay, thank you for that. What is any other thought from the other group members?
We have patient trust. I think it's better to disclose so that more damages are avoided.
So that means disclosure has to be policy.
Sorry, madam.
That's okay, yeah. So disclosure is the right choice. And also, as you said, that if you have built trust, so that means building trust, building rapport becomes so very essential in all cases, because if you already build rapport, if you have trust, patient would understand that you haven't done it willfully or you haven't done it, carelessly. So that's how they would view the error. I agree. Anything else?
I think in the present scenario, it's very, very complicated. Even if the patient believes you immediately, there'll be people to raise it up and he'll come back with a very severe reaction. See, even for normal situations where the doctor is not having any mistake, they are willing to even kill the doctor. So at this situation, I don't think any of us will be brave enough to disclose, even if an error had happened. I don't think it is advisable to. We have to be self-protective also.
So I completely understand from where it is coming, Dr. Harimohan, because the kind of reaction we are receiving from the patient and society on the whole, it's very scary. It's very, worrisome, I would say. And I understand what you're saying. So honestly, I mean, even I would say that, okay, go out and, disclose whatever you can and then, face the music. But then definitely some of the preventive actions can help us, one, to minimize the, possibility of error, or and then also, in case if we have talked about it, for example, certain complications, if we have talked in the initial stage, then we are talking about a procedure or a surgery, it actually keeps them, kind of alarmed or aware that, okay, this is one of the possibilities. So discussing at least the pre-procedure, aspect, we should do it in a more meticulous manner. Any other thought from any group member?
Rather than portraying it as an error from our side, we can, in a way, like in the example with Dr. Rafiq, and that guy should have actually immediately told that that was from his side, and also he could have portrayed it like there was a mistake with the needle, that when he withdrew the needle after taking the sample, that got broke or something, that would have prevented, I think so, but that's not the case with all the cases.
So I think Dr. Tanzil, you have brought in a good point. Creating an environment where people feel free to share the mistake or error. If you can create that culture where people can come out and accept that this has happened because of me, and let us do whatever best can be done at the earliest. But that means we don't have to punish the person. We don't have to blame the person for the error. But if you create a culture where the staff, the employees of the hospital come out openly and honestly and admit that this has happened, I think that's also one of the ways to minimize the damage to the patient part.
Madam, I would like to share one incident. Actually, I was in charge of the litigation cell for 4.5 years. So there was a case where a doctor, a gynecologist, there was a gauze left in the abdomen, and later they saw it, and it was removed.
Yeah.
And they asked for a compensation, and this is something called res ipsa loquitur. That is, it speaks for itself. You have no defense. So the out of court settlement was done, and they paid some amount of money. But then 15 years later, after that patient died, her children came and gave a case saying that the cause of her death was this foreign body in her abdomen. Just imagine. But then that time I was the secretary of that scheme. Then we went back into our records. It was 15 years back. We went back into our records and we fished out that agreement. And in the agreement, that advocate was smart enough to say that that lady had agreed that in future also there will be no litigation, and her dependents, all her dependents cannot come for a case later. Thankfully, that statement was written. So that is why it is very easy to say that, okay, we will confess our mistake and try to settle it and make it understood. But when you look at it at a legal point of view, I think...
So very honestly, I agree with you, Dr. Vasudevan, because every situation is unique. And you will have to take a call depending upon what are the pros and cons of going ahead with disclosure. We know if we disclose, this is the consequences, and we also know if we don't disclose, what kind of problems we can, we may have to face. So I'm not saying that okay, disclosure is the only, policy, and the disclosure is the only way. But you will have to really very mindfully think of how can we prevent the errors. I think that's where we can focus our energy. That is one thing. And second, in case if it happens, can we communicate? And okay, even if you are able to hide the error that has happened and that has not been brought to the patient's knowledge, but what will you do in cases where the mistake cannot be hidden? I think even that's a question to be answered, and we all need to be ready to talk about even that situation. So if you remember, there was a case in Delhi. The patient had to undergo renal surgery. One of the kidneys had to be removed, and unfortunately, the patient's healthy kidney was removed. I don't know if you remember that case or not.
That's all.
So how will you not disclose it?
Sridevi's mother was operated in US on the wrong side of her brain.
Wrong side of the surgery, yes. She underwent surgery and she was operated on the wrong side of the brain. So you can, what I'm trying to say, that not discussing about is not the choice. That's what I want to say. At least discussing about it will make us, little comfortable with the idea, okay, this can happen. Although we always say this should not happen. But what if this happens, and what if it cannot, cannot hide it? Then where do we go? That's the whole thing I'm talking about. So I think we have had a couple of exchanges on understanding that when it is easy to communicate, we are comfortable communicating. When it is difficult to communicate, we find it hard to communicate. Are we open to doing a role play on it? Are we open to doing? Can we take this case where we have operated on the wrong side, and unfortunately the healthy kidney has been removed? Or you want me to give an easier case?
Very difficult to convince also.
It's, wondering what you should tell to the patient.
Yeah.
Absolutely.
Convince ourselves. First, yeah.
I think all of us can become the patient bystanders, and madam can be on the other side.
Yes. The situation doctor can be difficult to role play.
Absolutely. So what I would say, situations like this, I would request you to take when you are doing role plays in your respective areas. That's what is going to open their mind to the idea of talking about it, learning about communication. Generally, if you go and say, learn how to talk to the patient nicely, nobody wants to listen to you. But if you pick up topics like this, how do you handle uncooperative patient party? How do you handle aggressive patients? How do you break bad news? How do you disclose medical errors? Take these elements, for discussion, and that is where they will open up and they'll be okay with the idea of having some training program. So we'd reduce the severity scale and take a case where the patient was mistaken for another patient and has undergone surgery which hasn't done any damage. I think this was another case in Delhi that happened. That patient had met with an accident. He was taken to the hospital for some stitches and some other surgery. But he was identified as another patient, and he was operated on by an orthopedician on his leg for fracture. But then, fortunately, it had not done any damage to the patient. The family got to know that patient didn't have any injury on the leg. Why was his leg operated, and why was he dressed up? So anybody is, wanting to take that case as a role play?
It is the toughest job, actually.
Okay. Let me do this. Let me do this for you. I think Dr. Paul last time had also asked that you have to do this role play so that we can. Okay. So anybody who wants to be the patient's family? And volunteer for the patient's family? Okay. Dr. Raja Lakshmi has raised her hand. And who is the second one? 2 members? Anybody?
Yeah, I can do. I'll do.
Okay, Dr. Mini. So let me show you the case and then we have a role play around it. Give me a second to So this is the case, and this is a real life case that happened in Delhi. So this patient was admitted, for multiple injuries after a car accident, and he had a deep cut on the left arm and needed subsurgery. He was mistaken by the resident and the staff nurses for another patient who had a broken leg. He was put up for surgery to repair a fracture, which he did not have. And you have operated on the patient, and the family is now wanting an explanation about it. Should I stop sharing, Dr. Mini and Dr. Rajalakshmi?
Yes, ma'am.
Okay, thank you.
Who is the doctor?
Madam,
Madam.
Dr. Paul wants me to do the role play, so I'm open to doing it because I'm comfortable doing it. Yeah. So can I request all others to switch off their cameras and we be here? Okay. So assuming that Dr. Sonia, can I request you to switch off your camera? Okay, thank you. Okay. So assuming that we have got to realize that this mistake has happened, and even you as a family have got to know. Let's assume that you both are Rakesh Tyagi's sisters. Am I right?
Yes.
Both of you are his sisters, and you are the primary caretaker of the patient. And how do you want it to be? You want to come and talk to me, or you want me to be calling you? How would you prefer?
We will come and talk to you, madam.
Okay, you will come. So assume that I'm in my room after the surgery, and both of you have come to me with your concern. So you have entered my room, and I'm saying hello. Mini, I recognize you. I think you are Rakesh's sister. Am I right?
Yeah, yes, madam.
Yeah, and who is this? Who is this
madam, we were told that he is having a cut wound on the hand, and now we see a plaster on the leg. We are really worried what happened to him. Actually, has something gone wrong, madam?
Actually, I was about to call you. I was just getting free, and I thought I'll just call you. And I wanted to tell you that there has been an error from our side. I had all the plans to come and speak to you, and I'm glad that you came asking for it.
But how can you make such a major error between arm and leg?
Ma'am, I completely agree, and I understand your concern. Actually, there were 2 patients with the same name. And incidentally, one of the staff members got confused, and she sent your brother in the OT, assuming that he's the other patient. Actually, the other patient had a broken, leg fracture on the leg, and that patient required surgery.
But when you can't make out that there is no fracture.
That's what the X-rays also that were shown to me were actually of the other patient. So assuming that it is the same patient, we opened the, we cut open the place, but then we realized that there was an error on our side. And then when we went into the details, we found that it was it.
Operation may put some stent or something, or
actually
only an incision, or you have done some operation also?
No, only an incision, because the moment we opened, we saw there was nothing, there was no fracture, there was no injury inside. So that is what alarmed us, because in the X-ray it was a clear-cut case of fracture. But when we opened the cut open, we realized that it was.
Madam, such a reputed hospital, how can this happen, madam? How can this happen? So you have to be very vigilant and very careful. It should not have happened in this hospital.
I completely understand your, you being upset and you being annoyed about it. And I take responsibility. I think it's a fault on our side. There has been an identification failure.
Madam, what do you want?
Anything else removed?
I'm sorry.
Anything else done, like anything, any organ, etc. removed?
No, nothing of that sort. Fortunately, the moment we identified, we immediately stitched the incision, and we have dressed him up. And the dressing, I mean, the wound will be fine in a couple of days.
How can we trust you now?
Ma'am, I understand that your trust in us has shaken. I completely understand the reason also. But I can only assure you that I'll personally look into it and make sure that nothing goes wrong and we look after your patient.
No, madam, enough is enough. We are going to take the patient out. No, we don't have any more trust in this hospital. No, because if this is the situation, then how can we rely for the further treatment also? No, anyway.
I completely understand that you want to take the patient, but what I would recommend that if we are in know of what has gone wrong, and if we are ready to look after things, I would suggest that you let the patient be under our care and we will manage it carefully. Because in any case, if you'll go anywhere, the procedure that needs to be done will be done. The treatment will be unnecessarily delayed.
That's your defense. But what would you have done if you were in our position? How would you have reacted?
No, I completely understand your anger and your unhappiness and dissatisfaction with us. And that's what I'm saying, that I would still suggest that you allow us to look after the patient. And
no, we want the X-ray of the leg and all. Again, we have to take it because we are not sure whether anything else has been done also.
I can get the X-ray done. I can, if you wish to meet the patient, I can, allow you to go and see the patient. He's fine. He's conscious. There's no, problem with him. I can get the X-rays done also in case that's what you're looking for more, clarity. That nothing, no damage.
No, madam, we are already totally worried. We are already worried about the accident and we are all here. We are not in a mood to discuss also. And you are telling you are already done a wrong operation on him. So you have to bear that also and this also, the brunt of attack. Both of these he has to undergo. Now, how much trauma he has to undergo? And what is the present situation of the already existing wound? It has not been cleaned or it has not been taken care of.
We have actually looked after the wound because the moment we realized that this is another patient, we brought his case and we have looked after that part, and that dressing has been done, that wound has been stitched. But in any case, see, both the things are going to take to heal, say a week to 10 days time. Let him be under our care. We will look after both the wounds, and he's already on medicine, so I'm sure the wound will really, he's a young man. He's not, he shouldn't take very long.
That doesn't mean that he should be operated wrongly. No, let us discuss, madam. We will talk to you later. Let us discuss.
Responsible, madam.
Sorry, no. I'm sorry, ma'am.
If he has any complications, we will hold you responsible.
I am saying, that's what I'm saying. Allow us to, like, if you let the patient be under our care, we will make sure that we, observe him well, and then whatever investigation needs to be done, we will do those investigations and accordingly manage it.
But sorry, we have trust in you.
I understand completely. I think it will be good if you go and see the patient once. I think that will give you more confidence in my words.
Before that, we have to talk to our relatives, madam. Then only we'll come and talk to you.
Sure. Take your time. I'm there, and in case if you wish to discuss anything or ask me anything more, feel free to come and talk to me. Thank you. So can I request everyone to come in?
Cannot be more aggressive.
No, I think it was well done, both of you. One question that you could have asked her was, why didn't you examine the patient before just seeing the X-ray? Why did you do an operation?
They told the answer, sir. That's why.
She
They
did not,
told no.
did not examine the patient. Only seeing the X-ray, she has done it. So that would have been a valid question.
But usually everything will be covered, and by the time the surgeon comes, no.
No. Before is taken up for surgery, the patient should have been seen by the.
This problem would not have come if she had examined.
Also, if you followed surgical.
Then, madam, what is your answer for that?
So
Madam,
I'll get back to you on this, but I want to say here,
if they ask
surgical safety checklist, if we followed that checklist, you can prevent most of the errors.
Yes, checklist is.
Surgical safety checklist.
And mark the site also.
Yeah, mark the site. And that's part of the safety checklist I'm talking about. So if we followed that checklist.
Site marked, yeah.
And I think last time also I discussed about a book by Atul Gawande.
Yes,
Checklist Manifesto. I would really recommend you all to read that book.
What would have been your answer if they asked for a compensation?
Yeah, that's
hospital expenses.
Yeah, that we are coming. We are going to talk with our relatives and make it a.
If you ask me for my personal opinion, this is like, ideally, a hospital should bear the cost of the treatment.
Yes.
Especially because of error that we have caused. How we divide that cost is our, responsibility. But then why should the patient bear the cost?
Yes.
It adds insult to the injury when you say,
adding insult
if you need to go undergo, another surgery because of my mistake, then you have to pay for the second surgery.
No, definitely not only the expense. The patient should be compensated for the pain he's suffering and unnecessary thing that was done for him.
So again,
it's easier to be a patient rather than a doctor, I think. Very convenient. We can.
But I feel it will be triggering them, and they will ask for more things.
Yeah, so that's what I was going to answer. So again, when I read some of the case studies of the other countries where they have a open, honest disclosure of medical error policy, they don't hesitate compensating sufficiently to the patient, because they consider they know the cost of litigation is much higher than the compensation the patient would ask. But in our country, we are still not open to the idea of compensation, or we try to bargain, or we try to minimize. There is no one-line answer. There can be a situation where, paying compensation would save you a lot of time, energy, and, unnecessary botheration.
But they may still go for.
But no, usually when you compensate, I'm sure lawyers make sure that the proper agreement is made between the parties, so that they can't litigate you, later on.
Maybe the hospital management will not allow these things, and they will tell the doctor to pay.
Exactly. That's what I'm saying. There is no one-line answer that's why now doctors are going for indemnity coverage, because they want the insurance, professional insurance, so that in case they are made to pay, then they have insurance. That's how things are now evolving. See, one thing is leading to another, and that is leading to another thing. And again, there is no, there may be a management who would agree to pay. There may be management who would say, okay, we'll pay half the cost or whatever. But that is something, again, you have to explore.
Similar case happened in Manjeri. Many people may be knowing. One child with the tonsillectomy, the other with the hernia. Both names are same. So they operated both opposite. And when they realized, then they operated the hernia also. It was a big case. I think like most of you will be knowing about that case. This happened 3-4 years back, Manjeri Medical College.
Okay.
I remember.
And then how did you manage?
I don't know what had happened later, but I don't know the minute details. It had come in the paper, and it was a big news for 1 week.
They might have negotiated, like they might have extended.
Yeah, that's it. So again, it's not a very comfortable conversation, but then we can't say that we don't want to talk about it. That's why I brought up this case here. And I don't usually we want to avoid, we don't want to talk about it. But then what do you do when the situation?
WHO checklist, see, it is given to all the hospital, but only 10% of the hospital or the doctors are practicing it. Surgical checklist is one of the best.
Time, they start shouting on the staff if they try to follow the.
Definitely.
They are wasting my time.
We might put the blame on staff, we might put the blame on the nursing assistant and everything, but ultimately we are answerable. That is the situation.
Yeah, exactly.
But what I can say is the disclosure of the medical errors depends on the damage that has been caused. Just like a simple error or a simple thing with not much casualty or not much complications, probably we might be able to think. And certain things which is not quite evident, but we know that it has happened. And there is not much to gain by disclosing also, and not much damage to the patient also, then whether we have to disclose or not. But certain things, as Rimas has said, it speaks for itself, like a mop or a pack that has been left. Anyway, if we don't speak, someone else will speak, then it is very difficult. Then we have to try. The first thing will be defensive, somehow to try to cover our side. Then only we will disclose. We are actually truly speaking, we people are not that much hesitant to reveal it or reveal the facts what has happened, but we are really afraid of the situations, the consequences. That is what prevents us from revealing the truth. But what I can just for some thought process, see, damage. There are so many professions in this world. All are professionals in one way or other. Each professions have their own errors. But when it comes to medical profession, it is considered as a huge crime. See, a pilot, a very expert pilot might make a plane crash. A loco pilot has made a train crash. A good swimmer who has been very good in swimming might drown to death. There are so many errors, so many faults that are taken. So human beings, there are some errors can happen. It's possible. And it is our duty to make it as much possible as to minimize the errors and do it to our perfection, to maintain all the protocols and everything. But as human beings, sometimes errors are possible. And the law should be there to protect all the profession, like other professions also, like we are also answerable. But at the same time, we are also eligible for the justice as a human being. So why we are not denied? We are denied of that. That is my.
I completely agree with you. I completely agree with you. The problem is, see, when there is a aggressive reaction coming from the patient party, probably at that time nobody cares for the law, and it's just the one person who is facing the mob is the one who has to, handle it. So therefore, I think right from the beginning, having good rapport, interacting with them, updating them, preparing them for everything, can probably help you to deal with that situation in a more, in a manner which is little safer than the other. Of course, now we are also talking about the concept of second victim, the person who has made the mistake and who is the one who is guilty and feeling bad about oneself. We are not talking about his or her mental health and her concern. That's also an issue to be discussed. But I think we need to understand this complex subject in more detail to really talk about it in a more detailed manner. So let me show you a small presentation on disclosure of medical error. Some of the points are something like when you break bad news, but then there are a couple of things that will help us understand how do we really go about disclosing medical error. So give me a second to share the slides with you. Okay. So if you were in a flight which was in a near miss crash and some passengers, including you, were slightly injured, what would you like to know, from whom and when?
cause for the accident?
It was more like a near miss crash.
Yeah, whether it was an engine failure or whether it was a.
No, that's we are going to, we will get to know once we talk to. But whom would you like to talk to? Who would you like to come to you and talk about?
The captain.
Captain.
Captain. Or also
The flight attendant.
Flight attendant.
Yeah, flight attendant. Or when you get off, maybe
Airline company.
Yeah. So usually if anything goes wrong anywhere, people want some understanding what exactly happened. So sometimes when we don't explain them, and sometimes when our team members go and talk about the case, then actually that complicates the situation. And in this case that you have seen, I'm going to share a couple of more cases, I think, if I have on my slide, where actual error has happened and the patient party has come to know. There's no scope to hide it. I think that is where we find it difficult to not to disclose. That's the most challenging. So if I may ask you, what is the clinician's perspective? How does that bother them? Or what do they think about it? If I may ask you.
They might be definitely depressed and very much the feeling of guilt will be there. Then how to face them and how to face the consequences. There will be anger, scare, anger, then panic.
Absolutely. So definitely, I think there's a fear of embarrassment and the aggressive reaction that can come. Risk of litigation, people asking for compensation. So all these things actually, worry anybody and would actually ask to cover the error rather than come out in open. Like we have discussed just now, and this is what has been the realization that people are not comfortable sharing because they know the consequences could be anything from simple verbal aggressive reaction to physical assault. So even very seasoned doctors find it uncomfortable and distressing to communicate medical errors because you don't know what is going to be the reaction. So this is another case that happened in Delhi where, a 51-year-old physiotherapist was admitted in the hospital and she had high blood pressure with ECG changes. But there was no treatment started on time and, things were delayed and then ultimately she went into cardiac arrest and she died. So again, as I said that some of the things you can't cover. You can't say that, okay, that was not our fault. This is another case where a 30-year-old lady was admitted for complaining minor abdominal pain. So she was identified as another patient, and they made a arteriovenous shunt for dialysis. And after everything was done, then probably they got to know we have misidentified the patient. So imagine, I mean, these are the errors which are clearly,
unforgivable.
More like carelessness, I would say, more like carelessness. So you can well imagine how the patient party sees the whole thing. So very honestly, I think medical errors like wrong side surgery, wrong medication, wrong organ removal, wrong treatment, wrong patient, they are very, very common. So this is the report I think I've shared with you earlier also. Yes. Medical errors are the third commonest cause of death. Almost like 250,000 patients die every year in US. We haven't done any study in our country. I don't know if we did, where we will stand. So you can well imagine what must be the magnitude of the error that we all are making in our practice. Only thing is it doesn't get reported, so nobody gets to know what errors are happening. This is another study by Professor Ashish Jha from Harvard University. He reported that he estimated that 5.2 million errors happen annually in India. I think it is an underestimation. It must be much more than that. Mm-hmm. Most of the errors are around medication error, patient care, and surgical error. So these are the areas where errors can happen. And again, most of the errors are because of the poor communication. Now, if we talk about certain definitions, which we need to have more clarity on. Definition of medical error. What is a medical error?
Harm to a patient.
Sorry.
Bringing harm to a patient secondary to our
Something which we could have prevented.
Something which we could have prevented. Anything else?
Anything done unknowingly. And
unknowingly, okay.
Something not done deliberately.
Unintentional.
Okay.
which has caused, which is not contrary to the our plan of action. Like we are doing plan to do a surgery on one side, then a treatment that is an error in treatment.
A mistake in diagnosis or treatment and realized after it is done.
Which
Dr.
may or may not cause damage.
May or may not. So Dr. Harimon has written an error in management, diagnosis, identification of a patient. Okay.
And treatment also?
Of course, of a treatment also. So medical error is failure to complete an action as intended or the use of a wrong plan to achieve an aim. It may or may not result in adverse outcome. I can see another answer in the chat box. Okay.
Management. Yeah.
I read it right. I did it. Okay. Again, this management or not, but that's okay. Yeah. Then unanticipated outcome. What is unanticipated outcome? Something that you were not
anticipated.
And that
and what is omission? What is omission?
Omission is deliberate.
Which was left out. Something which is left out.
It is not deliberate, but something that needed to be done and has been left out. Yeah. Something left undone. It's more of a neglect of it.
Act of omission and act of negligence.
Absolutely. So if you go by the patient's understanding of definition of error, it's very broad. They don't just go by the definition that we have discussed just now. For them, it includes even something that is non-preventable. So for example, a complication that is documented as one of the risks in a procedure, for them, even that's an error. Or poor service quality is an error according to them. Even poor communication is a definition, is part of the error from them. From our side, I think it's very narrow. Basically, if there is a deviation from the accepted standard, of care, we consider this as an error. And when we talk about the extent of disclosure, patients expect disclosure of all errors that has caused harm, or even including near misses. Whereas we believe that errors that has caused significant harm should only be disclosed with the patient. Then understanding how should the disclosure of an error happen. Patients prefer truthfully and compassionately. For us, we believe it has to be done in a more objective manner, minimal disclosure. Whatever can be avoided should be avoided, more in a matter-of-fact manner and in a very, very professional way. Again, if I may ask you, the role of apology. Patients expect.
Yes.
How about physician?
Yeah, this concerns that apology.
We may, but we are not happy doing that. We are also scared or worried that this might create a legal liability. If I say yes, there's an error, so there will be a kind of a legal liability because of this. It will be taken more like my confession to an error. If I say, yeah, I'm sorry, yeah. So when to have the conversation? Patients want it to be done immediately, as soon as possible. Whereas we consider that when we have all the facts, then we should speak to them. Also, sometimes we think that if we can delay it, maybe it will diffuse the situation, and then we can, share the information or have the conversation with them. And then also, what do patients expect, by the way, when it comes to disclosure? Write in the chat box, what do you think the patients expect? compensation. Always apology, compensation, yes. Compassion, honesty, degree of adverse outcome, how did it happen? Yes, any damage, truthful disclosure, honesty, truthful revealing, huge compensation, disclosure. So many of you have written, okay, Dr. Asha has written damage done. And then any possible complication. Again, damage, Dr. Vinny says, and then compensation, honesty, compassion. So many of you have written truthful, sense or agree. Yes, disclosure. So clearly it shows that somewhere patients expect us to be more, forthcoming with the information. And Dr. Asha has also written any future problems and how it happened. Absolutely. So studies also suggest that they want a statement that error occurred. So if we try to avoid agreeing to that, it's going to further, make them get irritated and then force you to say, yes, error has happened. So it's better to straight away agree that, yes, an error has happened, because that kind of makes them at least defensive for that moment. Then they want to know the details of what has happened. They also desire full disclosure of harmful error, even if the harm hasn't happened. Then implication to their health, any complication, any permanent damage, any irreversible, loss, they want to understand. They also want to know why it happened. How will the reoccurrence of this will be prevented? So how will you make sure that it doesn't happen to other patients? And then apology, and like many of you said, compensation. I agree with you. Now coming to the disclosure gap, 90% of the doctors support the
പൂച്ച മേലെ ഇറങ്ങി വന്നിരിക്കുന്നത്.
What is your pet's name?
So 90% of the doctors support the principle of disclosure, but only 30% of us actually do. That's the situation. Studies suggest that 2/3 of the errors are not reported. And then even if disclosure happens, it never meets the patient's expectation. And also, we don't hold any training. So naturally, people would not know how to go about disclosing it. So what are the barriers to disclosure? What stops the person from disclosing? What do you think are the barriers to disclosure?
We are scared whether we will get a bad name, madam.
Agreed. So there's a fear. There's a fear that we will be blamed for it, we will be held responsible for it. Punishment, yes, I agree. We fear that there can be a fear of punishment, aggressive response, social image would be affected, agreed. Fear of bad reputation, embarrassment, completely. I agree completely with the points that you are making. A lot of time, like just now we were discussing, many of us actually consider that is the disclosure really necessary? So when we have this kind of a mindset and we don't disclose, we don't even share with our colleagues, mistakes will keep and nobody will actually, take any corrective action or preventive action because nobody is reporting. So people don't get to know if errors are happening in the care. Then also some feel that it will unnecessarily cause distress to the patient and family. And especially if it does not harm the patient, there is no need to tell. Some also feel that patient is unlikely to find out if anything wrong has happened. So there's no need to call for problem. Of course, fear of retribution from the patient and the colleague is one of the reasons. Fear of legal action and financial judgment is another reason. Fear of having to handle the patient's emotions, because when they become very aggressive, extremely, agitated, there's a risk of violence, there is a risk of, physical assault. And then some also believe that disclosure is primarily a factual conversation and not a complex interpersonal conversation. So a lot of us do it in a more very objective and a non-emotional manner. And then believe that outcome is not related to the action on the part of person disclosing. So, and also there's lack of training in error disclosure. So automatically all this become barrier to disclosure and people are not comfortable breaking the barrier. Dr. Hari Mohan has written embarrassment, and then he also writes, I think that's why we need mandatory morbidity and mortality meets in all hospitals as a start. Absolutely. I think more we will talk about it, more people will get alerted, more careful they will become, more responsible they will become. But if everybody is trying to cover up, then nobody gets to know that there are errors happening right under their nose, and also there are ways to minimize these errors and minimize the damage. And it helps to in correction and avoidance too. Absolutely, that's what I was saying. That if you disclose, if you share, if you let others know, then at least others get alerted that these kind of errors can happen in their practice as well. So, what are the benefits of disclosure? What do you think are the benefits of disclosure?
Good sleep.
Peace of mind.
Peace of mind. Trust. Dr. Sanjil has written trust, peace of mind, more for patients. So, Dr. Harimon, what exactly you mean by more for patients, if you can?
Yeah, of course, our conscience become clearer, definitely.
Yeah.
But the benefit in disclosure is actually will benefit the patients better than the medical community.
So that means both of us, for us as well as for them, it's beneficial. Yeah. Clear consciousness, yes, completely. Then future mistakes can be avoided. I think that's what even I was saying, that we will
Be more vigilant.
Yeah, you will be able to prevent the future errors by, reporting the error that has happened in your care. So definitely, I think patient safety will be ensured, especially if by disclosing, you can save the patient from the future damage. If you can disclose and inform the patient to take care of something or avoid something, so definitely you are ensuring patient safety. Of course, it's an ethical and legal obligation. Trust and communication. Patient would have more trust on you and would believe that you haven't done anything willfully. And then also quality improvement, where the errors would start going down, especially when you start taking preventive actions based on the error that has happened. I can see two answers. Dr. Nabia says there is no benefit, that is minimal, almost nil, and possibility of backlash. Yes, Dr. Nambia, there's no doubt. But then definitely, okay, Dr. Nambia, if I may ask you, God forbid if it happened, something like this happened with you or your family member, would you want the doctor to not share with you, or you would prefer the doctor coming out and sharing that with you? You can please unmute and answer.
Okay. If I am in that situation, of course, I know this serious issue. But then think of the position of the doctor there. You'll have tension, anxiety.
So my question to you is, Dr. Nambia, if it was one of your family member or somebody close to you, who
The patient.
how would you like the doctor to come out and share that with you or not?
Yeah, that's true. Yeah, I expect the doctor to tell the truth. But
So
then
you
on the
cannot
other
have two standards of practice.
Yeah.
You cannot have two standards of practice.
Okay.
See, if I work responsibly, if I follow the protocols, if I follow the standard operating procedures, we can focus on minimizing the damage.
Okay.
We can focus on minimizing the error. But straight away saying that it's not going to help in any way, then trust me, errors will go on happening and nobody will report. And today or tomorrow, any one of us can be the victim of that particular error. So we need to have a more, unbiased and more professional approach to, errors, where we work on minimizing the errors by following the protocols. And then in case if error happens, how do we communicate if we learn how to communicate? And then whatever kappa needs to be done for that patient or for that any patient, that there has to be a proper protocol for that also.
Even if we admit that mistake, we may have to take care of the patient and their all expenses, everything we have to meet.
Yeah.
Yeah.
We are expected to be responsible in our way of functioning. I can't say that I have done everything that I could do and that the rest is not my responsibility. We will have to take the responsibility. So I can see a couple of answers. Madam, doctors alone can't be saint in society. I agree. I'm not asking you to be saint. It's a choice you need to make. I'm not saying that you go out and disclose. It's a choice you will be making in your own individual practices, especially when errors are not noticed or not, not others are not aware of that. I'm not asking anybody to be sent for that matter.
But even if we admit the mistake, they are likely to take us to the court. They will go with the legal action.
So I completely agree, Dr. Nambiar, because the situation is, very fragile right now, and we are on the defense. And I know the way society and the system is looking at us, and probably that's what has, brought us to a point. But who will clean my house other than me?
Madam, nowadays the problem is, whenever we break the truth, they are recording it. We have mobiles in their hand. They record everything, and then they use it as an evidence against us in the court of law.
Yeah,
I had actually written the second part, madam. When we are treated so poorly, even without errors, how do you expect to tell? I mean, I know I should tell my errors, but I am mortally afraid of what is going to happen to me. The society is so unfair to doctors now. So I think it is natural for us not to tell if possible. It is natural.
So I would say focus on minimizing the number of errors.
Alone, we cannot be expected. Already there is a thing that we have to be saints. When they ignore the other professions with all the errors, corruption, everything is going on, they never dare to hit them. How long will this happen? So
Dr.
this
I agree. 1 second. We'll
Yes.
be going out of the preview of this session if we are going to talk about that. Why I'm saying, because if any one of us had control over this situation, to change the situation, I would say go ahead and change it. I wouldn't say that no, disclosure is the only option. I'm not saying that. But I'm just making you discuss this point.
Yeah.
That if you don't disclose and if you encourage this practice, that's also not going to help us. That's not the way out. I think we'll close that discussion there.
No, I just want to tell one more thing, madam. I agree with you fully. Even I would like to disclose it, but in the present scenario, no. Halfway through, what we can do is try to clean our own stables. We should have mandatory morbidity, and it makes a big difference. Every month we used to go back through the cases. Some of us used to feel embarrassed because it was cases which we had done mistake. It comes out in the open, but we learned a lot. We were careful about that, but it was confidential. It never got out. All the cases that died, any problems we discussed, all the cases that had morbidity we discussed. I think India should first learn that, and then we come to this very difficult situation of telling to patients. That can happen, that will happen only later. But at least among ourselves, we should try it. A self-correction should be done.
I completely agree with you. See, if we think disclosing is not the right option right now, okay, park it aside. But what action are we taking to minimize the errors? Can we work on that? Can we work on that? Can we? You said morbidity.
We are doing.
We should have an in-house.
Yeah.
We should do have
auditing.
in-house
We
auditing.
are doing the auditing of all the maternal deaths.
Honestly, Dr. Mini, not many clinicians are open to the idea of even medical audit, clinical audit. You may be
Medical
open. I'm glad that if you all are open and you're already practicing it. Look
No.
at the global picture. Look at the general picture around. People are not comfortable with the idea. And I've seen it personally. They're not ready to talk about their clinical cases.
Deaths and patients who are near to deaths.
Yeah.
All the cases we are discussing, and we are formulating newer plans, and any change in treatment modalities, everything, it comes as pearls, and that is discussed and circulated to all the doctors in that profession. That is, in every
So
month we
maybe
are doing.
you will need to, again, this is a very important point that you are discussing. So if you think disclosing of medical error right now is not a good option, I agree with you. I accept that. I put it on the side. But what do you want to do? Have 1, 2, 3, 4, 5 plan of action. At least start working on that. Give that, because your audience is going to ask you in the same manner like you're asking me.
I would suggest mandatory morbidity and mortality means.
That's what I'm saying. So that is one. There can be many more ways that can help you to prevent errors. So very with an open mind, try to find out what all can be done to minimize the error. Can we focus on that? Even that's a good way to reduce the number of errors. I think that's what comes to my mind immediately. Okay. Now going back to the point that we all know most of the errors are brushed under the carpet and only few errors get reported. And also, let me tell you, very few patients actually go to sue the hospital or the doctor. Very honestly. Now, studies also suggest patients sue the hospital or the doctors not because they think there's a negligence. A lot of time when there is ineffective communication and then there's a lack of empathy and there's a feeling of being mistreated. And they also feel that essential information has been withheld from them. It has not been shared with them. So that means whenever they will feel that we are not open and honest with them, they would like to take away where we are forced to disclose every information with the court of law. So this is one study I'm sharing with you about where they practiced, the full disclosure policy in the University of Michigan. So they did the, they looked into 3 parameters, and that is their annual litigation cost, then average time to resolution of claims and lawsuits, and then number of claims and lawsuits. So August 2001, when they had not implemented full disclosure policy, and then they took the same parameters in August 2005. So according to their report, the litigation cost almost reduced to 1/3. The time taken to resolve the claims and lawsuits also became almost 50%. And number of claims and lawsuits also went down to almost 50%. I know we cannot take action based on these studies because these are the studies in a different country. But are we making any research on that? Are we studying some parameters which at least guide us? How do we go about resolving this limits? Are we open to doing some studies to find out what is the existing rate of litigation, cost that we are spending, and other parameters? But the thing is, we need to start looking into it in an objective manner. But just saying that we can't do it because that's the situation will not resolve the situation. It's going to further aggravate. So these are the guidelines I'm sharing with you for the disclosure of error. These are based on the certain, recommendations by the Canadian Patient Safety Institute and UK's National Patient Safety. I don't know how many of us really have this kind of a proper guideline or protocol in our country, standardized one. So therefore, we have to rely on the recommendations given by the foreign agencies. I wish we develop our own guidelines based on the reality situation of our country. I wish, people from medical profession come forward and develop their policy. So again, when there is no way out and the disclosure is the only option, when error has happened, it can't be hidden, it has to be explained. So I think we need to first of all prepare ourselves check how do you feel, how comfortable you are you ready with the information, are you ready with the answers that the patients may ask you for, questions they can put you across. So if you kind of prepare yourself for that kind of, intense communication, then you're mentally kind of ready that, okay, I'll have to face this. Then you can also seek assistance from your trusted colleagues. Rather than doing one person, it could be two, doctors working together could take up the task of talking to the family. So maybe they would actually be able to provide more confidence to each other. Then review all the available medical facts, because when they ask you questions and when you give the information in a more confident manner, they're more likely to trust you. They're more likely to agree with you. And then also prepare yourself for strong emotions, because there will be an extreme reaction coming from the patient part. When you are disclosing the error, it's again very important to begin by stating that there has been an error. A lot of time we fear that if we admit, they are recording, they are going to, take this as use this as a evidence in the court of law. There are so many other ways that they will try to prove you, to have done this error. So, but how you admit to that error and how you explain that error would actually be also considered when it comes as an evidence. Then also describe the course of events, how this happened, and in a very simple and non-technical language. That, like for example, the case I was discussing, I mean, honestly, I admitted that there were two patients with the same name, and we misidentified your patient and we considered that patient as another one, and then we kind of started this surgery. So when you explain them that, probably they understand the background of what has happened. When you're talking to them, use frequent pause, allow them to speak, because they may want to ask to you something, or they may want to clarify something. So for example, the role play that I did, both the sisters wanted to talk. I was mostly listening to them, and then I tried answering one of them. So if you allow them to talk, at least their anger kind of gets ventilation. And then state the nature of the mistake, consequences, and corrective action. Apology, I think we had discussed in a number of other sessions also. So in this case, yes, the apology is for the error that has happened. So it comes as a more like a personal regret. And then take their attention to the patient's welfare, because that's where they are more concerned about. But admitting that, yes, this has happened and I take the responsibility, does help to calm them down. We have discussed this also in the previous sessions, where we talked that expression has two meanings. One is expression of compassion, and then also taking responsibility. Of course, in this case, we are taking the responsibility of whatever has happened. When you say something like this, yeah, there was an error, but patient has not been harmed. Now, had I told these sisters that, yeah, we just opened, we had just given the incision, and then we realized that there is no fracture. But don't worry, it hasn't harmed the patient. It hasn't, in any way. So all those ways of apologizing would not help. So saying that there was an error, but it hasn't harmed the patient. There was a mistake, but this is one of the possibilities. Or the mistake did not change the outcome. The patient, in any case, had to die. Sorry for giving wrong injection, or sorry for not being able to call the team for code blue, but the patient had to die. So these kind of apologies definitely would not, taking responsibility, using I statement, do help in calming them down. And blaming your staff, blaming your residents, blaming others, blaming even patient party would not help in any way to cool the situation. Invite questions if they have something to ask, what are their concerns, because again, that will give you an idea of what they are thinking and how they are taking it. Make a follow plan with them. Explain the next steps, what you are going to do. Like, for example, I kept insisting that both of you please go and see your brother. If you'll meet him, you will feel better. Even he will feel better once he meets you. So you are kind of trying to, let them see the patient. A lot of time when they see the patient and the patient seems okay, even that reduces their anger and And then discuss how to meet the needs of the patient and family. A lot of times they'll say, we want to go and see the patient ourselves. If you can facilitate, if you can allow, it would be taken as a good gesture. Plan for next update. And if you inform that, okay, patient is under our observation and in our care, and I'll keep updating you maybe in 3 hours or 4 hours, especially if the case is very critical and there can be changes in the patient's condition. So regular updating is very important. I think this is one thing very important where you need to be accessible. If they want to contact you, if they want to ask you anything, if they want to meet you, and if you are not accessible, if you say, I am busy, I can't talk, I don't have time, I think that would upset them and give them a feeling that you are avoiding to meet them. Once you have updated them, it's important to document, report the incident and the action taken, rationale for the clinical decisions that you took, whatever the clinical outcome was in the further plan of action that you have planned. Discuss with the patient and family in detail. Whatever discussion you held, you have to note down. Tell who all were present in the discussion and the questions they asked and the answers you gave. And then of course sign and the date and time that you need to make a mention. After the situation is over, again, I would say it's important to sit and reflect. A lot of time we say something that we shouldn't have said. A lot of time our behavior sometimes is not appropriate. So when you sit and reflect, we get to see how we have done, how could have we done it differently, what are the better ways of doing it. So sit back and self-check in how you felt. Discuss with your colleagues, they'll give you good ideas how to handle such situations, how they have handled. Like for example, we talked about 5-6 situations all of you have shared. When you came across a situation when there was an error in your care, so how you handled that. So that experience sharing also helps in preparing oneself for similar situations. Of course, reading material to update how one can do this in a more effective manner, and then attending program to learn crisis management or situation like this is a good way to at least slowly get acclimatized with the idea that there is a possibility of error and there can be a possibility where I need to talk to the family. So just by not talking about it, just avoiding this is not the way out. So this is what we have actually discussed till now. Of course, at the institutional level, we need to integrate disclosure, patient safety, and risk management activities. That's very important. I think people should become comfortable with the idea of coming out in open and saying that this error has happened. So establish a disclosure support system, provide background disclosure education, ensure disclosure coaching is done time to time so that people they open up. That's the main idea. And then of course, provide emotional support for healthcare workers. As I said, for even there's a concept of second victim. So we all should pay attention to this aspect also. Create a culture of patient safety so that you can minimize the number of errors. Create a culture of employee safety also so that they feel that they are protected by management and people around them. And a culture where people report errors promptly without fear of repercussion. Usually people don't come out because they fear there will be a repercussion. And use performance improvement tools to track and enhance disclosure. So whenever any disclosure is done, even that can be, assessed how the whole thing went and what could have been done. So I know this does not answer the real question of what you are facing in the real situation. But at the same time, I feel some discussions should start happening. Because ultimately, we can't keep avoiding discussing. What do you all say?
Can't avoid.
You can't. You can't.
I'd like to just, based on whatever discussion has happened, I think when we express the fear of actually revealing a medical error, I think the unsaid part is, especially in India, that we are alone once we discuss the error. We may not have the support of our colleagues, the hospital we work with, let's leave the larger society alone. I think the hospitals, the medical system itself, we are alone to actually tough it out. And I think the fact that because practice in India is very individual based and there is not a systematic response or support that is given, I think that is one part of it. The other part is when what Dr. Mini said that any error is complete and utter negligence. That is how the public perceives it.
Yeah.
The unsaid thing is that, see, we had met a lot of doctors earlier, and this has never happened. They were always careful. Errors don't happen from doctors. So it is because you are negligent. It may sound very philosophical, but the part is that so the purpose here is how do we have perhaps a lesser incidence of aggressive reactions. So the fact is that the public should be aware that medical errors can happen. The only way that can happen is if we are open about it. But at the same point of time, right now, the systems here in India, and I'm not talking about the perception of the general public, within the profession are inadequate to support someone when such an so that is the challenge we face. And I think the purpose of the program is to inculcate and give this message to the younger generation. Unless there is a modeling, it is never going to happen. So I think these are the tough questions that we need to, deliberate about, think about, and see what is a pragmatic way ahead in India. Because I don't think what is done in Michigan probably would work here because there was the institutional systematic support that would have been there. So how can we actually ensure that? Right now, it's just the IMA, couple of IMA representatives, a private organization. That is not how it should be.
Yeah.
So I think these are the dilemmas.
I completely agree with you. But I think more we will start discussing about it, more solutions will come forward. Like you said, we don't have a support system. Then maybe you will start thinking of creating support system where we know if there is somebody, like nobody would willfully do an error. But if something goes wrong, how do we support that person so that that person feels that there are people around me who will come around? But if we don't talk about it, if we just brush this under the carpet, then the person who is facing has to face it all alone. And not that by not talking about it, things wouldn't happen or aggressive reaction will not happen or the errors will not get noticed. These are very pertinent questions, what you're saying. But then they require discussion. I mean, you could even consider having a brainstorming session on it. You could consider having one-day discussion, roundtable conference around it, so that we start talking about it and then we come out with some ways out how to minimize, how to take corrective action, how to take preventive action. Some beginning has to be made somewhere.
Professional backstabbing is.
I agree with Rajashri madam. I think that is the different scenario now. In older days, those doctors also had their errors, which some were covered up, some were in the professional community, yes, but not to the patient. Now, a lot of errors do happen, and the errors are, if it is pointed out by another professional, is when the issue becomes more aggressive and issues come in.
Exactly. So again, professional jousting can be taken up as a topic of discussion between doctors. It could be taken as a mission to tell everyone that that's not the way, that's not going to function, and how that can damage somebody's reputation and somebody's career. That has to be.
Maybe we should talk of professional etiquette.
Yeah.
Actually, this is the topic that is the most difficult topic we all were having, because up to this session, all the other topics we were able to somehow handle it, because even with good communication skills or whatever, a little more pragmatic or little more empathetic way, we may, with training also, we may be able to communicate in a better way and handle those situations. But the disclosure of medical error is the most toughest and the difficult topic. and very difficult to practice also, especially in a country like India, where they actually there are a lot of problems that are prone to make errors also, because a person who is actually in abroad and all abroad countries and all actually a doctor is supposed to see some 30-40 patients, less than that only. But in a situation like here, in a heavy OPD, when a person is seeing more than 100 patients, actually, even from the base of the rules, base of the job, so many changes has to be take place. The
Dr.
definition
I
of
completely agree with you. The anomalies are enormous. I'm not disagreeing to that point. See, even like you said, we can't go about disclosing because there can be aggressive reaction. I am also agreeing to that point. I'm not saying no, be saints and come out and have the beating. No, I'm not saying that. But some action has to be taken, corrective action from our side.
yes,
That is what probably is my concern.
Yeah,
and one thing, like we say, we don't want to do this. Okay. But what will you do in case if the error is right in front of everybody? If I've amputated the wrong foot of my patient, how will I cover up?
Yes, madam, that's what we are saying. It is the toughest job we have to address. Yes. And so many plan of action has to be formulated. At the same time, the topic that of medical error has to be made little more familiar to the public as well as in all community, the society, because they don't think that only doctors make make crimes or errors. All professions as human beings are subjected to
But
errors.
nobody will listen to that justification, Dr. Mini. I think we can, in between us, we can talk like this, that no profession is error-free and therefore why should we be victimized? But nobody is going to listen to that justification. I think because our energy is able to see whatever we can do in our best capacity.
Yes, at least in the court of law, at least we can say that this must see so much percentage.
Proper communication, procedure, consent, informed decision making. These practices have to be more, apt and in place, so that at least these practices save us tomorrow in case if something goes wrong.
So preventive steps for
absolutely, a lot of emphasis on prevention that we can give.
Preventive steps.
Okay, so this was in nutshell about disclosure of medical error. It's not the end, it's the beginning, I would say. So I would really expect all of you to do brainstorming on this together and come up with your own resolutions on how do you want to deal with it to prevent aggressive reaction. I had requested Dr. Vasudevan to talk about medical ethics in today's session. What time it is? It is 9:40. So, and also I had requested Dr. Ramesh to join today when we close this session. So maybe Dr. Vasudevan, if I request you to do this in 20 minutes, is that okay?
Excuse me, madam, can I be excused because I had to drop one person in the railway station.
It's okay. It's okay.
Sorry for that.
No, it's perfectly all right. You can please go ahead. Yeah. I think the main session is complete. I would have actually loved having your feedback.
I'd like to hear sir's speech and the other one also. Unfortunately, unavoidable, I have to go for this.
Yeah, no, that's okay. We understand and you have attended this session. It's okay. Please, you can leave if you want. And
Sir can give the feedback and go.
Sorry?
Definitely.
Sir can give the feedback and go.
Yeah, maybe
Thank
that's
you. I'll see in the recorded version.
No, we want to hear your feedback. That's what probably she's saying.
No, that will definitely be there, but I'm telling what I'm missing now, I'll see in the YouTube also.
Yeah, of course. Yeah.
And bye to everybody. I hope we'll continue in our sessions.
Would
and
you like
madam,
to give your feedback for the program now? But in the
most
video.
indebted to you for having trained us in such a nice manner. So much we learned. So grateful to you. Thank you, sir. And to everybody else for this wonderful team, which I could be part of. I'm sure we'll continue and we can do more. Thank you.
Yes.
There is something, Dr. Harimohan, you should try to change. The first day, madam had told you something.
What is that?
Black and white.
You have to sit, not the light should not be
opposite.
from the
Yeah. But it's over.
No, the last meeting, that was
Yeah.
not evident.
Last meeting I had a net issue. So I was actually sitting with my mobile actually.
But
That's right.
initially you started with black and white. Now it has become color.
Good riddance to bad rubbish. Thank you all.
Thank you, Dr. Harimohan. Thank you so much.
Good night.
Bye-bye. Good night. Yeah.
Ma'am,
So-
may I ask two questions? Actually, one is to you and one is to the rest of them.
Sure.
One is about the topic and one is out of topic. My first question will be to you. Will there be some certificates issued to us from Institute of Healthcare Communications or something?
Yes.
So,
there will be a certificate issued by IFC.
okay, the rest question is out of curiosity, don't take it otherwise. There was a case mentioned by Dr. Paul about this adrenaline being injected than ephedrine or something. So after this class, I would like to know how many of you will be revealing that thing. To be honest, you can raise your hands or something. How many of you will be revealing if such a thing happened that nothing will be nothing happened afterwards other than high blood pressure, no? So how many of you will be really revealing that to your patient if such thing happened to you?
I will not.
That is what we told. No, it depends on the damage that has been caused and the how much it is evident and how much it speaks for itself.
And no, nothing actually happened to the patient other than the
so then
hypertension. No?
in this
That's why
present scenario, we won't. Frankly, no.
That's what I think we discussed, that there's a realization that there's an extreme aggressive reaction that comes from the patient party. But like Dr. Menon mentioned, that his staff gave wrong medicine, one patient's medicine to another patient. This is a recent incident that he has shared. And he did talk to the family and he did explain to them that this is what has happened. So maybe again, you would say it was an oral medication and that was a different situation. And this is a parenteral, medicine. So there's a different thing. And the outcome was different. In this case, BP will shoot up to 200 something. And in that case, not real much difficulty or distress was experienced by the patient party. So I think we have realized this, that it's not easy. I'm not expecting that after this session that you will go out and say, okay, I'm going to report all my error. The idea is, let's talk about it. Even if that starts happening, I would say this session has served the purpose. I don't think before this, anybody sat and talked about disclosure of error like this.
Then actually Dr. Paul should have appreciated that resident for actually telling the truth.
Yeah, he told me
actually only one of us
3 years,
raised our hands.
after 3 years, that time he denied. Then see, when he denies, we will think of a different
Other reasons.
Other reason. If
Actually,
you would
his
have told
passing
me
and all will be-
or whispered to me saying that it is the same drug, then we won't think about it.
Yes.
Much about it. So,
But Tansil, the revealing of the whatever crime or whatever thing he has done is among doctors only, to other doctors or colleagues. That we all do, because sometimes it happened, I mistakenly did that. We all will be talking with us in a when we have such a company. But revealing it to the patient is something different.
As Mini said, in that particular case, as a PG, I think we all would have revealed.
We
are also going through a learning
we
curve.
learn by
We would
mistakes.
have revealed to the doctor at least, not to the patient.
we reveal
The
it.
senior, we would, I think. Majority of us would.
Yes.
Madam,
Okay,
how many, how many, like our this YouTube, who all will be seeing this?
That is what I am concerned when we are talking
nobody
about.
watches the 2 hours program other than the participant. Tell me, how many sessions have you watched?
How many?
Actually, the average
say
view rate
all.
is
Not
40
that, other than us, somebody else can watch this.
Yes, anytime
It's
can be.
there, but I haven't seen anybody watching the full length of a full program, honestly.
Actually, the average
If
view
it's
is
not
around
so,
14 or
I
something.
wanted to share
If
something.
you don't want me to put it on a public, this thing, I can do that. I will not put it on public. I'll keep it private, but I'll share the link with you. Is that okay?
I think it is better.
We can do that.
Can I share an incident?
Yes.
Because it pops up, madam, whenever we open the YouTube channel, it pops up MTP training program for doctors. It is coming up like that.
There was one thing, this was 15 years back in a different country. Okay, means one case was done under anesthesia. Not done, it was started by one of the consultant, and the patient had a cardiac arrest. When the superior, the anesthesiologist, went and checked, he found, when and checked means like he checked everything, he found the tube was in esophagus. It was not in endotracheal tube.
Sure.
So I wanted to ask you, if you are the one who has checked it, what will be your reaction? What will be your next step?
I think first and foremost is how would you go about saving the patient?
No, the patient is already cardiac arrest, dead.
So whatever the steps as a clinician you need to take, I think that should be the focus, because you want to save the patient in that situation.
No, here the patient is already dead, and you know what is the mistake. And the mistake, the superior has already seen the mistake.
So again, what you're
I'm asking everyone actually.
Yeah.
Not.
I want to also tell you that I was taking a session for a group of nurses who said that we sometimes want to report whatever error has happened in OT. We are actually shouted at by doctors and prevented to report them. So I am sure in that case, if the surgeon had more, say in the system, he would never let the anesthetist come out with that.
Vice versa also, madam.
Or vice versa.
Vice versa also, because staff's mistakes sometimes we are covering up.
Yeah, that's.
But now what has happened is the person who put the tube till now has not realized it is in esophagus.
Yeah, many of
Till
it
now,
happens.
he doesn't know it is in the esophagus. And the superior never revealed it till now.
Then you must be the superior, no?
I won't say the things like this is what has happened. So whether it was done correctly or not, the patient died. Hope you understand the situation.
Yeah, but
whether the superior did the right thing.
The superior should not have.
The superior
junior person is still.
But you become part of the. I don't want to use word crime, but part of the error.
But superior should have informed the junior. It is learning from an error, right? He has to learn from his error. So the error should have been.
How to? Yeah, he should be taught how to prevent it.
Yeah, to the junior, yes, not to the bystanders or whatever the situation.
Because the superior didn't inform, the person is still working abroad. The junior is still working abroad. Otherwise, he would have been checked out from there.
No, you could have told him privately, not.
Yeah, not in front of them.
Not official reporting, but at least for a learning process, he should know.
Because he could do
usually
again,
yes,
and the other senior person may not cover him.
Yes. Usually I do like that because many often the staff might do something unknowingly, and what I do is I call up from the situation from that and to my room personally, and when no one else is there around, I will talk to her. See, this has happened. You should be very careful. That is what I'd never shout in front of the patient or the bystanders about the error.
Naturally, that wouldn't be fair. Yeah. Thank you. So I think Dr. Vasudevan is ready with his presentation.
Ethics. Now ethics.
Allow me to share the screen.
Yeah, sure. And then after this, I will inform Dr. Ramesh to join before we close it. I'm sorry. Yeah. One second. Let me allow you to share the screen. So Dr. Vasudevan, can I request you to complete this in 20 minutes, if that's okay? I know you have.
It will more than 20 minutes.
Okay. Go ahead, please.
Yeah. Can you see my screen?
Yes, we can.
Yes, yes.
Well, Can you hear me?
Yes, we can.
Yeah. Good evening. At the outset, let me thank all of you and especially Indu ma'am for giving me an opportunity to talk on medical ethics, which is my passion, and I lose no opportunity to talk on ethics. Well, I would love to have had it on a physical mode, but then positive time prevents me from even interacting that we had been doing all these sessions. But anyway, I'll try my best to make it as interactive as possible. The topic is medical ethics, a bane or a boon. Well, let me tell you that I've been traveling the length and breadth of the country talking on ethics, and I had faced many questions. But the most common thing that I've faced all over is why should doctors have ethics? Why only we should have ethics? And since doctors come under the Consumer Protection Act, shouldn't we be having business ethics rather than medical ethics? Well, as you know, medical ethics is a system of moral principles. And these moral principles are laid down for proper professional conduct. Now, my question to all of you is that how many of you actually think that we are traders and not professionals? Anyone who feels that he's a trader, not a professional, I just want you to raise your hand. I don't see anyone. Okay, fine. But then the perception by a large section of the society is that we are traders, because a large overwhelming majority of doctors are working in the private sector, where they work for fee and they charge for the service being rendered. On the other hand, people, when they come, when they're sick and they come for a treatment, they pay money on the spot for whatever service they have received. And thus buying medical care is concrete, repeatedly experienced, unpleasant reality. And the perception of people being traders, doctors being traders, is from this daily experience of cash transaction or the fee for service. But on the other hand, we doctors, through our education and training and historical tradition, are taught to believe that we are professionals and we do everything for the well-being of the patients and not merely for trade. And the fact that we deal with life and death enhances our feeling that we are professionals, and a professional without ethics would be a trader. Now, we say we are a professional. Then what is the difference between a profession and a occupation? See, profession and occupation both is a source of livelihood. Can any of you tell me what is the difference between profession and trader? Except Mini, because we had discussed this a few days back in the IMA hall. Can anyone tell me what is the difference between a profession and an occupation? Anyone?
Profession has an ethics or rules to follow.
Good. Anything else? Well, positive time. I'm interrupting. Well, a profession means it's got a special characteristic that there is a curriculum for it, and there's a structured training and an orientation program, and end of which their exams are conducted, and you have an end certification, which is a recognized qualification. Merely having a qualification, you cannot practice that profession. You have to be registered. For that, you should have a registering authority. That is the Medical Council of India before, and now we have the National Medical Commission. And this registering authority maintains the register, and having been conferred with this registration number, we are having a privilege. But only we who are registered can practice, who have MBBS and who has registered can practice modern medicine. But at the same time, these registering bodies, as Tanzil mentioned, that they set about certain core ethical values which we are bound to adhere to. And this registration is for a valid period of time. Usually here it is for 5 years, and there's a renewal of it based on certain rules that we have to have 30 hours of CME. And these registering authority has certain statutory jurisdiction. That is, they have the right to look into the breaches made by us in medical, in medical ethics or misconduct or even medical negligence, and they can award penalty for it, requisite penalty. It could be just mere warning. It could be for 3 hours or 3 months or 6 months, 1 year, a permanent removal from the register, depending upon the gravity of the mistake we have done. So then, when I had gone to Maharashtra, one of the doctors asked me, fine, you say all these things, but why does this registering body have to set an ethics? I felt that was a fair question. But can anyone you tell that why should we have ethics? Why should profession have ethics? Anyone? Again, Vinny, please don't answer because we had discussed it just 2 days back in IMA hall. Why should we have? Yesterday in the WhatsApp we had discussed.
The job we do is with a certain high level of responsibility.
Okay, partially correct. Well, again, I am interrupting. We should have ethics because this practice of medicine has a special characteristics which is not so profound pronounced in any other profession, because we deal with people or patients when they are most vulnerable. At that moment of time, the patients are totally dependent upon the integrity and the technical knowledge of a doctor. At that moment of time, the doctor-patient relationship is loaded heavily in favor of the doctor. He comes to us because he is forced to come. He has no other option. And whatever advice we give, he has to accept it. And so the patient's attitude is a complex of trust basing on our integrity, on our professional competence, and a mistrust because of the position in which he is, the vulnerable position. I think I'll simplify it. Is saying, suppose a person brings his mother to us with an MI, and we examine and say that, okay, you have to have the thrombolytic agent injection tenecteplase. It costs rupees 50,000. See, it's a case of life and death. He will agree to it. But if someone whispers into his ear and tells him that this is an obligation, this doctor has prescribed because he has an obligation toward the pharma company, which has sponsored his foreign tour last month, then there is mistrust. And once there is mistrust, there is the entire doctor-patient relationship is lost. Suppose a patient brings his father with an impending stroke, and you say that you want an MRI scan. He will do it. But if someone tells him that it is for the 3,500 rupees commission he gets from the scan center, again, that trust is lost. I think this is where ethics come. This ambivalence in this doctor-patient relationship is addressed by medical ethics because it guarantees to the patient that the doctor will not misuse his dominance and will not do anything that is not beneficial to the patient, even though it is his source of livelihood. So medical ethics is actually a regulatory mechanism. Now, this code of ethics has been there, not now, it has been there from the pre-Vedic periods. It has been in the Charaka Samhita, the BC, the Hammurabi code used to be there. It was the nobles and commoners and slaves. We were paid then itself. Again, even then, the chopping of the physician's hand in case of failure was there. In the BCs, it was there. And the Hippocratic Oath started in 5th century, but we used the modified version. And now we have the professional conduct ethics regulations, and which has laid down a high standard of conduct, which is responsible for maintaining the sanctity of this medical profession and helps us to say that we are professionals and not traders. This MCI code of ethics is going to be changed. The new draft has come up by the National Medical Commission, but the final version has not come. Till then, we will be following this MCI ethical regulations. I would say that ethics is a lighthouse. Because it helps us in dealing with several medical dilemmas. And that is the most important. It helps us in medical dilemma. It navigates us or helps us to guides us during the turbulent waters of various medical dilemmas. Can any of you tell me what are the 4 principles of medical ethics? Anyone? 4 principles of medical ethics. Anyone?
Beneficence, non-maleficence.
Very
justice,
good. Very good.
Fidelity.
One more. And
Fidelity.
Autonomy. The 4 pillars are the autonomy or the 4 principles. Menon, you have said the rest: beneficence, non-maleficence, and justice. When you talk about autonomy, what I have to say that, it's a huge topic. All these are huge topics. I just want to put it as short as possible. Autonomy means every person has the right to make decisions. And it is the responsibility of every individual, that is a doctor, to respect the autonomy of others. When I say others, I mean patients. Autonomy is the byproduct of human dignity and human rights. Can any of you tell me in the simplest way, what is human rights? The definition of human rights? Anyone? Human rights are the rights that all people have by virtue of being a human being. If you're born as a human being, do you have certain rights? And the beauty of it is that it is defined internationally, nationally, locally by the various lawmaking bodies. And the most important thing is that it is supreme. It is inherent, that is, it is inbuilt and is inalienable. That is, no one can take it away. And all these ethics are based on this human right. Whatever laws are created, it is based on this human rights. And consent, we have talked about consent in our classes, these communication class. Consent is an integral part of autonomy. And the ultimate test of autonomy is transcendent choices. Can anyone tell me what are the transcendent, example of a transcendent choice of autonomy? Anyone? Well, transcendent choices means, see, a patient may have to choose between a life full of sufferings, or he can reject further treatment so that it leads to an early death. Because life and freedom from extreme agony are basic human values associated with human dignity. The DNR, that is, do not resuscitate. I think you must have all heard DNR, do not resuscitate. This is one thing where a patient can decide, yes, no more I should be resuscitating. If he gives in writing, you as a physician is bound to accept that. And you should not resuscitate him. He can even take you to the court of law for having resuscitated after if he has given in writing that do not resuscitate. Another example of transcendent choice of autonomy is sexuality. See, a person can decide whether he would like to have sex, whether he would like to have children, whether he would like to undergo sterilization surgery, or whether he would like to undergo treatment for infertility, whether he would like to undergo change of sex, undergo sex changing surgeries. These are all individual things, subjective things. So these are the autonomy which an individual has, and we as doctors have to respect this autonomy. And this autonomy has come from the way that the horrendous, during the Holocaust, the German physicians had done a lot of inhuman activities, the freezing experiment, even babies were given poisonous gases. The fibula of a woman was removed and transplanted. These are all prisoners of wars, and they were transplanted on wounded soldiers. And then came the Nuremberg trial, and then came the Nuremberg Code of 1947, the Helsinki's 1964, the Belmont Report, the ICMR guidelines. These were the things. And research activities, that was Edward Jenner in 76, who talked about the cowpox vaccine. The John Gregory was the Scottish physician who gave lectures on duties and qualification of a physician. Claude Bernard was a French physiologist who insisted that all human experiments should be preceded by animal experiments. The Major Walt Reed in the yellow fever experiments was introduced the first systematic use of informed consent and protection of subjects in research. We have now the ICMR guidelines when we do research activities. Coming to the other pillar is the beneficence and non-maleficence. Again, here it is the main important thing is you have to maximize the benefits and minimize the risks. And the benefits and harm may be physical, psychological, or social. And ultimate goal of any medical intervention, as a doctor, the ultimate goal of any medical practitioner should be that there should be medical benefit to the people. This should be ultimate goal. Futile medical. Can any of you give me example of a futile medical intervention? Anyone?
Mercy killing.
Pardon?
Mercy killing.
No, mercy killing is not a futile medical intervention. Futile medical. You are near that, but not that on the spot. See, suppose a patient is a brain dead. Putting him on a ventilator, except if he is a person who is willing to donate, I think it's a futile treatment.
Yes.
A surgeon who is operating on a stage 4 patient, and you know that your treatment is not going to alleviate his sufferings, but still you continue that. These are all futile. Don't attempt these futile medical interventions. It is unethical. Sometimes you're forced to do certain intervention, even though when you know the damage is severe. Can any of you give me an example?
After road traffic accident.
Pardon?
Amputation?
Yes, very good. I don't know who said that, but it's a very good, the correct answer. It's a amputation. See, a gangrenous limb or a cancerous limb, you do an amputation. Yes. I know of a doctor who confessed to me that she was feeling very bad. It was a gynecologist. Many must have faced the situation. Actually, it was a doctor's child who had to undergo the suffering. Was because she was treating that doctor's daughter, and she was having one side of a fallopian tube was totally blocked because of PID, and the other side she was treating her for infertility, and she'd had ectopic pregnancy. The patient came in shock, and she had to do salpingo-oophorectomy. So that was something which she felt very bad, but that is part of our profession. Every doctor should realize to have this cost benefit analysis. It is very important to have this whenever you treat, whenever you decide on the options of treatment. See, all of us would have liked the fourth option, that is high benefit, low cost. But a low benefit, high cost, low benefit, low cost, we generally roll. But high benefit, high cost, there are sometimes we are forced to do. I said, as I went to Gujarat, one doctor told me, "Doctor, it's fine that you're talking about all this ethics, but I have a problem." I said, "What?" See, whenever I try to be ethical and restrict my surgeries or unnecessary surgeries or investigation, the HR department, that guy comes and tells me, "Doctor, can you justify your salary last month?" I have not generated enough income for the hospital to pay my salary. So then I am forced to take up surgeries, or I am forced to take up treatments. I'm so forced to take up investigations, which I would normally not have recommended. So that leads to high benefit, high cost. ECMO, that is, extracorporeal membrane oxygenation. I think, yes, that was actually, we all heard it during the treatment of Jayalalitha. Yeah, Jayalalitha. But then it is now being used 1.5 to 3 lakh rupees per day. But just because some people can afford, and just because the hospital has these equipments, please don't try to attempt it in a case where, as I said, futile intervention, don't try it. But these do happen. I just wanted to highlight these points. Another incident that I would like to say is the what we see during the pandemic. There was a lot of hue and cry. There was a lot of debate on vaccines, the co-vaccines, and the Covishield and Covaxin, whether the proper clinical trials were not done, adequate clinical trials were not done. There were a lot of complications, a few complications are there. But then, in a situation where these immunization program is likely to immunize 1 million people against an infectious disease, it's a fact that a few complications here and there, we have to look at the net balance of benefit over harm. So these are the ethical aspects, ethics which come in to take decisions. Technical booms, a lot of technical booms, I'm not enumerating all of them, but then these are the technical, because of the technology and the medical science development, we are coming to a lot of ethical dilemmas. The PCPNDAT Act, it's considered to be one of the most draconian laws, the prenatal diagnostic test, because of feet. But I have always asked this question. The ultrasound machine came first. The diagnosis, the ability to diagnose the sex of the fetus came second, and then came the PCPND Act. This PCPND Act came because some of our doctors, black sheeps, they went around in using the portable ultrasound machine, diagnosing the sex of fetus, resulting in unnecessary fetal feticides. And now we can't blame the government for it. Because of this, the focus, that is point of care ultrasound. Ultrasound machines are not just used by radiologists, they are used by gynecologists, they are used by anesthesiologists, they are used by orthopedicians, the emergency department, all of them use this. But then their use is restricted. There's a lot of regulations to using. Even echocardiography machine, there's a lot of restriction. In foreign countries, we have handheld USG devices, the smartphones which are used, but unfortunately in India, we can't use it. But the highlight of this female feticide is a social problem. Why do we have this female feticide? It is because of the most important reason, the main reason is dowry. It is a social problem, but unfortunately, we are trying to find a medical solution for a social problem. And that is where our system, there's something wrong with this law. Organ transplantations have been using this issues, the donor, recipient, allocation of limited sources, procurement. There's a lot of controversy we had about organ transplantation, at least in Kerala. Informed consent. Should a person whom a transplant has failed be given a second organ? Should individuals who have abused their bodies through smoking, drinking, receive organs? These are things which have come up. The art, the assisted reproductive technology, I think many will agree with me. There's so much of ethics involved in assisted reproductive technology because so we have to be aware of these ethical guidelines. Genetic engineering. Genetic engineering is the most highly developed technology where there are a lot of research activities is going on. We have they say that we can control Parkinsonism. We'll have treatment for Alzheimer's. There's even for malignancies we can find out treatment, very congenital problems. But then, if there are no proper regulations, there is a possibility of having a designer baby. There can be a baby, there can be people who will, Hitler can form such things, high IQ, no inherited. This will be a disaster. It will be a disaster for humanity if you have designer babies. Again, I'm not going to see justice. I think this is an important pillar. Why I said was justice is very important because everyone should be aware of this justice, because justice in the context is the principle to decide how much it is compatible, whatever we do, whether it's compatible with law, with the patient's rights, whether it's fair, balanced. And what all of us should know is that the last sentence, which is, no one is unfairly disadvantaged when it comes to healthcare. And this is the principle why free treatment is given in in government hospital. At least a free prescription is given. The level of free treatment being given varies from hospital to hospital. But this is the very basis why a free treatment is given. And I always say that all those who are involved, the lawmakers and also doctors, whenever I take classes for these youngsters who just joined medical service, I said, if you are going to be in the administrative cadre, And if you are one of the persons who are going to make policy decisions, you should be aware of the component of justice in medical ethics, because there's a lot of things which you decide how the resources have to be handled, how the access to healthcare is managed. Elements of justice. There are two things: how you share the resources. One is equality. That equality, very simple. Equality means you share the resources equally. Equity means you share the resources among the various components according to the needs or according to the departments. So equality is this: everyone gets equal share. I think I'll put it in a much better way. See, this is equality. All of them are given the same share, but you see that fellow in the small fellow in that violet shirt, he's peeping through. He's not enjoying like the other two people, because the resources, though the resources, all of them have been given help, but that guy is not enjoying. But then this is equity. You give that small fellow a little more, and then you see his joy. He's shy, he's excited. And look at that red fellow, he's getting distracted because of the excitement of this fellow in violet. But so that is equality and equity. But the liberation, this is, but what we really want is to take away all barriers, and that is liberation. But then what is the reality? The reality is this: the rich, the powerful, the influential siphon away the resources, while the poor, the powerless, and the underprivileged are pushed down. And this is because the government spending on the health sector is very low in India. Even after 75 years of independence, we spend just 2.1% of the GDP, whereas the world average is 6%. And as a result of which, we have poor accessibility to the healthcare and poor availability of healthcare. This is what very often we see in government hospitals, the situation like this. And I just put this things, abuse of power, that's because this is one reason where we should be careful. There's a lot of the print media, the visual media, all right, bring out these things: the abuse of power, cuts and commissions, hospital mints money on heart stents, patient payers, doctors follow corrupt practices. Dolo tablet, there was a huge hue and cry about 1,000 crore in freebies. And medical education. I think this is one important thing. Many of our colleagues are going as ghost faculties or fake faculties. I think it's a big crime, because you are hitting at the very essence of medical education. You are facilitating half-baked doctors. And I always tell some of my friends who go as fake faculty, I'll say, you don't do it, because you do not know who will be visiting this way. It may be your own relative, it may be your own child who may have to approach a half-baked doctor, and you face the consequences. So be careful, I always tell. Well, this is a very important thing. That is why I put this: a physician should expose without fear of favor incompetent or corrupt, dishonest, or unethical conduct on the part of the members of the profession. This is very important, but we don't do it. We talked about all these unethical activities in our living room, but never bother to tell it boldly. Napoleon had once said, "The world suffers a lot, not because of the violence of bad people, but because of the silence of good people." And finally, I would say that ethics is the most dynamic thing. It keeps changing. The ethics which was 30 years back is not what it is today, because as I said, technology and the medical science has developed so much that keeps changing. And what is the first thing? That is legally correct, ethically correct, no problem. Legally wrong, ethically wrong, no problem. But there are situations where this is legally correct and ethically wrong. Can any of you tell me an example of legally correct and ethically wrong? A situation. Legally, you are legally correct, but you are ethically wrong. Legally, you will not be blamed. Anyone? Well,
medical termination of pregnancy.
No, that is you are not. If you don't do it at the right time, then it is the other way around. You are legally wrong. I'll tell you. Yes, I just tell. See, if you don't expose a person who is corrupt, you are not legally wrong, but you are ethically wrong. Okay. You advertise some of the hospitals advertise the names of doctors with photographs. There's nothing legally wrong in it, but you are ethically wrong. You take freebies, cuts commission. These are not legally correct because there is no legal aspect to this, but you are ethically wrong. Now, okay, other way around. Can any of you tell me what is legally wrong but ethically correct? I think one was Tanzil said was okay, fine. IMTP, I would agree, but anything else? Anyone else? Anything? Well, POXO Act. I think many would must have had this experience. POXO Act. See, sometimes the mother and the daughter, the mother and the daughter will catch your feet and beg to you, please don't tell, don't reveal it, because our family's reputation is at stake. Please don't do it. See, and confidentiality. We talk about confidentiality, privacy. Ethically, you may be right in not telling, but if you don't reveal it, you had it. A criminal case will be hosted against you if the police comes to know. So that is, you are legally wrong. Another one problem is the POXO, is the PCP and DT Act, where you have a sex-linked disease and you have to reveal it, isn't it? If you reveal it, you reveal the sex of the baby. My wife, who's a radiologist, had this problem during the pandemic. There's a condition called, adrenoleukodystrophy. It affects the brain, the myelin sheath of the brain and spinal cord, and it is X-linked. So it is mainly seen in severely seen in boys, a male child, and not very severely seen in females. So this lady, the first child was a male, he had adrenoleukodystrophy. The second was a female, no problem. Now the third, she's pregnant the third time, and she wants to know the sex of the baby. She comes up and tells my wife, please just tell me if it's a male. If it's a male, I will abort the child. See, it is male feticide. It is not female feticide. It is a male feticide. She says, you please tell me if it is a male child. If it is not a male, I will have to go to Vellore for other further investigation, amniocentesis, this chorionic villi sampling and all that, and further treatment. But I can't go during this pandemic to Vellore. So please tell me the sex of the child. She couldn't tell her. She couldn't. She refused because it is legally wrong. If someone comes, her registration will go. She just refused. But this is a severe ethical, it is ethically correct if you tell it. It is a severe ethical dilemma where doctors face because of these problems. Well, finally, the final thing is that we needed to promote the values of trust, accountability, and mutual respect. It is required, ethics is required to build public support for medical care. We earn respect for the medical profession because of medical ethics, and we promote moral and social values such as human rights and social welfare, and it promotes medical standards. Thank you so much.
Thank you so much, Dr. Vasudevan. To have ended the whole program with this talk by you on medical ethics, I think.
I had to rush through, madam. Positive time.
I know. It should have been at least a 2-hour session to get the finer details of it. So I think we have Dr. Ramesh Kumar with us. Sir, if you could have your camera on, that will be nice. Yes.
So disclosure of medical error is ethically wrong or ethically correct and legally correct?
Good question. Good question.
It is ethically correct. But how legally it is not legally wrong also. You can say that, but you'll have to face the music.
If you don't disclose, then
yes,
is it ethically and legally wrong? I think that's the question.
No, it is ethically wrong if you don't reveal, actually. It is ethically wrong.
Even legally also wrong.
Legally, you can't say it's wrong.
If it is found out, it becomes legally wrong.
Yeah, because there is no law that says that you have to reveal all things to the patients. Only that ethics says that autonomy of the
Patient's
patient.
right to information
Yes.
asks you to disclose this information with
Yes.
the patient. Yes, that's the idea. So I think with this, we come to the end of the program. Thank you so much. All of you have been excellent participants. I think the moment I switch on my Zoom, I have people waiting to log in. All 10 sessions, I can say so. So it's been a real great pleasure interacting with all of you, having very wonderful, insightful discussions. And all of you have really come out with very wonderful questions, insights, and also incidents that you shared. I think it was rich learning for all of us. So I asked Dr. Ramesh to first address the group, and then I'll ask for everyone to give their feedback.
Yeah, good evening, all of you, and good evening, Dr. Indu. So let me thank you for taking up this responsibility to build up this team of 15 very smart people who will carry on this program for IMA Kerala State Branch. Before I think I speak further, I would like to hear the feedback from the participants, their experience for the last 10 sessions, because we had planned 10 sessions. And actually, all of you might remember, we had initially planned 2 sessions every week so that this exercise is over in 2.5, maybe means in a lesser period, because almost 2 sessions a week means 5 weeks, 1.5 months maximum, so that we can roll out this program of training the doctors and other healthcare providers in the state. Anyway, we took 2.5 months for the convenience of the participants. Even though the state president was a bit annoyed with me, saying that it is too long, 2.5 months. But still, I tried to convince him that the convenience of our master trainers have also to be looked up. And so we were accommodative, and we thought, for the convenience of all, let us have it at a 1 week session. Now we have to make up the time, because our ultimate aim is to train the doctors and the other healthcare providers in the state. And so we have to make up for the lost time. And I'm sure, without further wasting much time, we will be able to chalk out a program where we all the 15 master trainers whom IMA Kerala State Branch has sponsored for this beautiful 10 session program by Dr. Indu Arnaja, who is a master trainer of international repute and a very veteran and very expert in this field. So now the honors is on all the 15 participants. So I would like to hear some feedback, if not from all the 15, a few of you, and then we'll chalk out the program for the future. So again, let me thank Dr. Indu. It is indeed a great privilege for us, for IMA Kerala State Branch, to get the services of yourself for training of the master trainers. And I wish we could train more people under you. Let us hope we will find out some other strategy to do so. And let us hope that your 15 students under you will not let us down, and see that this program moves ahead in our state. So thank you, Dr. Indu. Once again, I have no words to thank you at all. And it was also a good experience and pleasure meeting you at Trivandrum last Sunday. And definitely your interaction with 15 participants, online sessions, 10 sessions, as well as your physical meeting at Trivandrum, but I immensely helped these participants, I'm very sure. So over to the participants for their feedback, and then let us see what we can do.
So who would like to start?
I think all the 15 can chip in for a minute, no issue.
Good evening to you, Dr. Ramesh. And I actually wrote a big full paper feedback. So I'll just read out. Nothing like that. But actually, I'm immensely grateful and thankful to you, madam, because I think your presentations are really good. Each session, we all had our energy and enthusiasm increasing, each session after session, I must say that. Because I'm sure that was very palpable, isn't it? And and we learned so much, and only thing is now the ball is in our court and we have to carry this forward, and let's see how with your guidance even further, more days to come and months to come, I think we will chalk out a module and start doing our part to save our doctor fraternity from any more violence. Thank you so much.
Can I?
Yes, please go ahead.
Yes. Yes. First, let me thank Indu ma'am and IMA for having given us this opportunity and seeing us through this training program. Actually, this Indian Institute of Healthcare Communication was itself a news to me. I didn't even know such an institute existed before I came into this program. And I realized that this could be a huge science, which each session opened up new avenues, saying, it was even to, a person who's been practicing for 30 years, communication classes meant just communication skills, soft skills, as ma'am mentioned in our introductory talk in Trivandrum. Healthcare communication is a totally different scenario. And that realization, you took us through that, through these 10 sessions. And beautiful, true professional. Everything is done very professionally. You're a very sincere person. Can't help mentioning that, ma'am. You're a very, very sincere person. From her heart, she wished us to become good trainers. And that is another important point I wanted to mention about ma'am is, this is the way we should do adult facilitation, is what I learned from her. Like, we all were made to feel that we were equals and not learning from her. Like, we all were contributing. She at least made us feel that we were all contributing, though we knew at heart of hearts we were not contributing the most. 90% contributed by ma'am. Yet we were given that feel. I suppose that is the feel we should also be given for our adult facilitation programs. That is when you get more engagement of the audience. That is the main part I learned from ma'am. That is a way for any relationship, I would say, but then for a facilitation program, that would be the best. Hats off, ma'am. Thank you very much. Thank you for the program. As Raki said, the onus is on us now. Hope we can do justice to the trust IMA has given on us. Our efforts, our sincerity will always be there. I suppose time is the most constricting factor, being all busy professionals. Hope we can do justice. Thank you. Thank you very much.
Yeah. Yes. Thank you, Indu madam. Thank you, Ramesh sir, for having such a wonderful class, because the 20 sessions had gone very fast. And even though it was weekly once, we never felt it like that, because it has been a very good time. We all were having a group discussions, and it was the first time we all were eagerly waiting for Tuesdays to have our share, to have a mutual understanding, and to have Indu madam. You have to say especially about Indu madam, because she has done 100% justice to her job, because she made us think, she made us act, she made us some many brainstorming sessions, and finally we all have learned very much from her, because initially we thought, what is there much in communication, because we have been a lot of classes on communication skills, but when we heard each and every session, we found that it is not such an easy job, and ma'am has made it very simple, very attractive, and we never felt boring, like, because the two sessions might sometimes end up with 3 or 3.5 hours, and all the different pedagogies, we have learned, because only by through this session, because we knew only a PPT, earlier we knew only some role play or storytelling, but the other so many pedagogies were new to us, and there were a lot of brainstorming sessions. We all belong to different specialties, but still it was not an entrance. Ma'am was a person who is from outside the profession, but we never felt that, because she was much experienced than we all. Then we had different discussions, very fertile discussion, very much interesting interactions. But anyway, many thanks to Chairman Dr. Ramesh and our state president for arranging such a session. Now the question is how we are going to make this fruitful, and how to make it useful to the society, to our profession and all. So first thing, I feel we have to go through all the sessions that we had. Then we have to sit together. We should realize what is the burning issue that is faced by our profession, and what all ways we can deal with this by having a group discussion and by forming a uniform sort of plan of action and protocols and SOPs. And depending on the audience and the like whether it is for the staff or it is for the doctors or it is for the public, we have to modulate the different topics. And meanwhile, we all will meet in between and share our experience, and also share our plan of actions, and make this very useful to the society as well as the profession, so that at least we have that satisfaction in us for undergoing this, and for all the sessions also. Thank you, madam.
Thank you so much.
Thank you, IMA, for giving this opportunity, and definitely Indu madam, only thing what I have to say is joining this program has been definitely a turning point in my professional life, because now after joining these sessions, definitely my approach has changed a lot. And at times I think how Indu ma'am will assert in such a situation, or how she will communicate in such a situation, even that thought comes to my mind. Definitely, whatever we have learned, we'll try our best to impart it to our other colleagues. And I'm really thankful to have such a nice group of, we have become like a family. We meet every Tuesday, and it's like, so we'll continue with this. Thank you, madam.
Thank you so much. Thank you for wonderful feedback. Thank you.
We missed you at Trivandrum, Lata.
Yeah.
Even Mini also, we missed Mini, we missed Tansil. We missed four people there.
Actually, we missed all.
Yeah.
And can I make a comment, Dr. Ramesh?
Yes.
Myself, Dr. Mukundan Nambiar.
We're not able to see you.
The video is not working. There's a problem with me. No, to sum up the whole thing, I only one word, that is excellent. We had very close interaction all these days, and we got a lot of information from our madam, Dr. Indu Arnaja, and from now onwards, we have to start planning for the future sessions. And I think all the 15 teammates can sit together and plan the modules for the future sessions. Thank you.
All the sessions were very much enjoyable, and even though in some sessions went up to 11, we never felt bored and we never felt sleepy also.
You're muted. You're muted.
Please unmute yourself. Deepa, please unmute yourself.
So you didn't hear anything?
No, we heard. You carry on.
Okay. So, and the whole pedagogues were, so many pedagogues were new to us. We happened to learn about Kahoot very interesting interactions, discussions, and brainstorming sessions. And actually, I thought I was a good communicator, but after attending the sessions, I came to know what all problems I had, and I have personal gains also. So the communication is not only important in our profession, it is important in our family also. So I started talking about communication in our family also, to my husband, and even my sons also. So in that way also it benefited me a lot. And now what next? That is very important. This is just a beginning. Now we have to try our best for future training programs. We have to work hard, and we have to plan our sessions ahead also. And I'm so much grateful to IMA Kerala State and also to Indu ma'am. Indu ma'am's composed nature and the way she dealt with the sessions, that also we have to learn so much from her also. And thanks a lot. And all the co-learners were very enthusiastic. And after 1 or 2 sessions itself, it became like a family. And now, sad that this is going to end.
No, this is not going to end.
No, the sessions
It's going to be a continuous process.
Sessions.
We may miss Indu ma'am. She may not be a regular feature for us now, but the 15 people will be. It will be a continuous process.
Thank you.
Okay. First of all, I thank Dr. Ramesh for selecting me among this 15. It was a great opportunity. And in between, when he said that 2 days in a week, I called him and said, it is difficult for me, please send somebody else for him. Then he said, you start moving on and then we'll see. And it would have been a great miss if I had not attended. So thank you very much for that. And you have what all the plans you have, we will definitely take that to greater heights, and we'll see to that each doctor will be given imparted this knowledge. That we will definitely do. And ma'am, I used to think that she always wear white. Today she has come with red. I don't know how many people have recognized, seen that. It was good to see you there, madam, well dressed and well polished, and the really nice talks. And where she wanted to impart or wanted to stop us, she was doing that also. And the correct knowledge was imparted to us. It was a great thing, definitely, and glad I could hear Dr. Srikumar's ethics talk also. That was really great. So we will definitely take this to greater heights. Thank you.
Good evening, ma'am. First of all, let me thank Dr. Ramesh for identifying Dr. Indu Arneja. That is the greatest thing. There would have been many people, but he told me that we are good friends. He told me she's a master trainer. You will go and attend her classes. That is how I joined it. Anyway, thank you, ma'am. Thank you, Ramesh, for finding out Dr. Indu and allowing us to have interactions with her. 10 superb classes, excellent classes of the highest order. And what I liked best was the way she managed all 15 of us. She never said we were wrong. I think all of us made mistakes, but she never said we were wrong. She would always say, yes, you're right. But then, and she would, that was her communication skill. I would say, I have learned a lot from her, the way she communicated. And I think that is our biggest task of communicating with the rest of the doctors. And the pedagogies which she introduced, we made us aware of. I think these are things which goes a long way, not only but it will be in our lifetime. I think it will be very useful. I go around giving talks, but I I will definitely use these pedagogies there. Another thing was that we had we have attended lots of other trainers coming and training, but they were not something associated with medical situations. They used to tell in general, like we used to how you should smile, you should do that, you should do this. These were general things. But here we were given situations where actual life situations where how to deal with it. That was the best part. That is something which we had, at least I had never experienced. I had attended lots of communication classes, but it was to be entertainment. Here it is not entertainment, not merely entertainment. It was entertaining, but there was a lot of knowledge. There was a lot of matter in it, actually, which for a doctor. The rest was only entertainment. I think all of us would have forgotten it, but here we won't forget it. That was the crux of the situation. I think we have a long way to go, and we have to envisage methods of imparting whatever she has told us, at least a part of it. I don't think if we can impart the entire thing, but definitely we have a huge responsibility. And I think the biggest gift we can give to Dr. Indu would be the way we go further, how we go further, and how we really impart whatever she has taught us to the rest of the doctors of Kerala State IMA. And I think Ramesh will be managing overall. He'll be having an idea of how things, and wherever we go wrong, I request you to tell us that how we should be proceeding further. Thank you so much, ma'am, once again, and wishing you all the best in your future endeavors also.
Thank you,
Kumar. Actually, when the state president and state secretary asked me to chair this committee, I thought I will make it different this year. Because still last year, you all know, all of you know, communication skill means we'll have one meeting somewhere in Trivandrum or Kochi or Calicut, and some of our usual IMA leaders will attend that meeting, and someone will come and take one hour or 2 hour class. That's the end of it. So this year I thought we'll make it in a different way. So I started finding out who is the best person, and then Dr. Indu's name came up. Then I interacted with her. When I interacted with her, I gave her the idea what is our requirement, and she's a real veteran, and so she could understand what is our requirement, and she has done full justice to this. That is what the difference we have made this year. We thought instead of making it one meeting, actually I thought Dr. Indu will come for one meeting, but she herself told that let us have a pool of master trainers, and she told me minimum 10 people, maximum 15 people. That was what she told me in the beginning. So that's what I thought, let's have maximum 15 people. So that is how we selected you 15 people among the applicants. There were many applicants. We selected 15 of you, and we put into a very useful training under Dr. Indu. So this year we have made a change. Now my objective this year is, rather I'll not say my objective, the objective of IMA Kerala State branches. Now there's 15 master trainers who have been trained for 10 sessions. You have a dual role. One is you also need to impart training from another pool of master trainers. I'm sure you are all competent now after attending these 10 sessions. So we'll have more master trainers on one hand, and on the other hand, you'll also be a trainer for training doctors and students or whatever other the other healthcare providers. So we will plan in such a way that your professional work or you are not put in, your professional work is not affected, or you are not put into much of a personal inconvenience. But at the same time, we want some commitment from your side that we should have some minimum this much sessions. Today is June 26th or 27th. Today is June 27th. So by July first week, we should be imparting some training programs throughout the state. So our IMA year usually ends by November 15th. Means that is when the state president and state secretary during our state council, the office bearer stage. So we have July, August, September, October, 4.5 months. This IME year, we should make these 4.5 months count and see that we train more to the maximum people. So we'll have the program, no issue. For that, I think we will have a physical meeting in the coming days on a Sunday where your professional work will not be affected. Somewhere in the middle where everyone can come and just go. You don't have to travel much. And we'll have a brainstorming session very soon. And we will be able to chalk out a very good program. And definitely Dr. Indu's help will be there throughout, I'm sure. She'll be guiding us, mentoring us. And I'm going to ask the State Secretary for sanction for one more batch, if possible, because let us have another batch also. So let me see if it works. I think we'll have similar 10 online session batch of 15 is what I feel, because from the feedback I got from the 15, means almost everyone are unanimous in their opinion that it's a very effective and very useful session. And my request to all of you, and I'm very happy that all of you say that your personal communication skill has improved. I'm very happy about it. But our objective is to improve the communication skill of maximum doctors and nurses in our and the students in our state, because communication skill as far as the health system is concerned is very unique, and it's a very important aspect because there's a lot of issues in the healthcare system, and there are a lot of situations which requires a very good communication. So we will plan accordingly, and definitely we can move ahead. I think, Dr. Indu, it's already 11, and you may not have, none of you might have had your dinner. I am sitting up for my dinner. There's no problem, because you might have started at 7:30. So I think it's time for you to wind up also. So if anyone else wants to have a quick comment, can do, and otherwise I will ask Dr. Indu to sum up and close the session.
Just a few words, sir.
Yes, yes.
Thank you, Dr. Ramesh, first of all, for having chosen all of us. And I think we should give the major thanks to IMA for having thought of this program, because I think it's the need of the hour. The number of issues have propped up where communication has failed. So, so when we thought of a master trainer, we only thought of many sessions of do's and don'ts. But then it turned out it was an all proactive session where she made us pitch in as much as she could, but she would never go off the line. And it was very, very informative. And each session was important and a lot of information. She kept the worst two for the last, because they are the most tricky situations of medical errors and breaking the bad news. I think she kept it for the last, because that's where I think we all will falter. So I think we have a lot of insights into all this. So I thank you all once again, and I hope we can live up to the expectations of IMA. Thank you.
Yes, Sindhu ma'am, it's over to you now.
Thank you so much. I think I really wish to congratulate IMA Kerala State for the initiative it has taken. Most of the times when I offer such programs, although I don't go offering any program to anybody, ask me honestly, I just put it on LinkedIn and people contact me and they take the program. This was the 10th batch, but I don't think any organization as an organization has come forward to train a set of doctors with the purpose and the vision that they want to really, impart this understanding to all their healthcare professionals. It's a unique initiative taken by IMA Kerala. I honestly congratulate you and also feel that you really need to bring change in your, work culture and also the dynamics that you are experiencing there. Having session with all of them has been very enlightening, very enjoyable, very interactive, because they were very enthusiastic to learn and understand. So probably that kept me going. Although I do my level best for every program, but I think this batch will always stay special to my heart because one, being all doctors and being very senior in their position, they're not like freshers who would just come with no experience and would just listen to what I say. But then they had a lot to contribute. They shared very happily. They talked about their incidents. They talked about even their mistakes, the errors that they made. That takes a lot of courage to talk about your failures and your errors. But I thoroughly enjoyed every session, honestly. And therefore, spending 2 hours, 3 hours, 3.5 hours, 4 hours, I've never counted the number of hours that has gone in this session. It's been a rich learning for me also, trust me. I thoroughly enjoyed. You have taken the benchmark of the program to a greater height. I really need to now choose people to meet that benchmark. But thank you so much. Thank you, IMA Kerala. Thank you, Dr. Ramesh. Thank you, President and the Secretary, for even conceiving the idea of having a program like this. But it wouldn't have been possible without the participation and enthusiasm of the participants. They have been a wonderful audience, wonderful participants. I mean, they have actually put their position aside and just attended the program like any participant. I think that made the program very interesting, very enjoyable. And I'm thankful to all of you to have been there. Thank you.
Thank you so much. We have no words to thank you, actually. We express our sincere gratitude. And of course, we will definitely take your guidance in future also for moving ahead.
Anytime. I'm there. Whenever you want, we can have a discussion. Zoom discussion. Yes. We can have anytime. I don't think that should be a challenge. So should I close this session?
Yes, we'll close this session. And this is an official
session.
Before closing, it's the official 10 online sessions are being closed now, but we will continue we will meet once a week, every week, and definitely we will follow up our plan and follow up our activities.
Thanks.
Thank
and
you,
I
sir.
request
Kahoot is
everybody.
here. Dr. Sri. Kahoot.
Madam, oh.
You didn't see this?
Yeah. So kindly share your exact names that you want on the certificate, and I'll get the soft copy of the
So what we'll do is, ma'am, you send the certificates individually to, or you send all the certificates to me. I wish to ask the state president or any of our dignitary to actually distribute the certificate at a function, so that everyone understands that they are the 15 master trainers who have been trained. So they will be given the certificates in most probably the next state working committee or any important state level meeting. We will ask our state president to distribute the certificate so that everyone recognize them. They are the master trainers being.
We could even consider having a joint certificate issued by IMA Kerala and IFC.
Definitely. So we will, you put your signature on it, and I'll ask Dr. Sulfi to put his signature.
Yeah. And we could have both the no, but then we have to design it. So maybe have a designer to.
Yes. We can.
Share.
We can do that. No issue.
Sure, we can do that. Yeah. So thank you so much, everyone.
Thank you,
ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you. Thank you, and good night.
Thank you.
Bye.
Good night.
Good night.
Thank you all. We shall meet again.
Hopefully, yes.
Yes, we'll definitely call. We are planning to call Dr. Indu ma'am for one physical meeting somewhere in Kochi or Calicut, not in Trivandrum. Last time you came to Trivandrum. In next 2 months, we'll plan one session in another place, maybe Calicut or Kochi.
Sure.
So we'll meet you then.
Thank you so much. Good night, everyone.
Good night.
Good night.
Thank you. Good night.